So, good evening, everyone. So, welcome to this fourth session of RSA Youth Conclave 2025. We had three very exciting, very thrilling uh, sessions earlier. This is the fourth one, and we have today 9 speakers, and three of our esteemed chairpersons are here with us. And I hope, like the rest three sessions, this too will be very exciting and thrilling, and judges will have a tough time in judging the yuva of this anesthesia of this country. Special thanks to Dr. Naveen sir, President RSACP, who gave us this opportunity to conduct this uh, RSACP Youth Conclave on such a large scale. Uh, Thanks to Dr. Tej K. Kaul sir, patron of RSACP, who always joins and always encourages us, and he motivates us. And because of this only that we have started practicing 15-20 minutes before. Sir, thank you very much for joining. Thank you. I also welcome Dr. Vishal Singla sir, Secretary RSCCP, and he has been very instrumental. He's been the guiding spirit behind this entire show. I I welcome all the three chairpersons and the speakers. All the best to all the speakers. But before that, a few words from Dr. Tej K. Kaul sir, our patron. Sir, please.
Good evening and welcome to all. Do you hear me? Am I audible?
Yes. Yes, sir. Yes, sir.
Welcome to everyone whosoever is attending this Yuva RSSC Youth Conclave 2025, the fourth in the series of this year. It is a great brainchild of our President Dr. Naveen Malhotra and very ably supported by Dr. Vishal, the secretary, and all other members, particularly Dr. Naveen, particularly Dr. Tanveer. So, all the best. Wish you all the best. And let us start with the academics. All the best. God bless you all.
Thank you, sir. Thank you so much. A few words from our president, our respected Dr. Naveen Lothra, sir, the man behind the Yuva activities of anesthesia of the country.
Thank you, Dr. Tanveer, and heartiest welcome to the session 4 of Research Society of Anesthesiology Youth Conclave. We normally declare the results at the beginning of the next session, but since some participants are common in the third session and the fourth session, so we shall be declaring the results together for both the sessions. And I'm really very proud of Dr. Tanveer and Dr. Neha Sinha, the National Youth Coordinators, and Dr. Nitin and Dr. Neha Mishra, the State Youth Coordinators, for spearheading our vision of promoting youth at each level. I warmly welcome our chairpersons, Professor Sandeep Sahu, Professor Anil Verma, and Professor Tanmay Tiwari, the trio from Uttar Pradesh branch of Research Society of Anesthesiology, and Dr. Anil being the National GC member also, and the organizing chairperson of the RCP Con 2016 Kanpur, Professor Sandeep Sahu.
Good evening, sir.
Good evening, Dr. Anil. Professor Sandeep Sahu also has been our National Governing Council member and president of RCP Uttar Pradesh State Branch. And Dr. Tanmay is also RSCP Governing Council member, state representative, and is a very, very active member of Research Society of Anesthesiology. And it's my profound pleasure to welcome the three chairpersons. And also, I pay my regards to Professor Tej K. Kaul and extend my warm love and regards to Dr. Vishal Singla, our honorary secretary, and welcome all the delegates to today's session. I'm sure today's session will be an absorbing session like the previous three sessions. Best wishes to all the participants. All of those who are participating are winners already. I also place on record the presence of our National Governing Council GC members, Professor Meenu Chadda, and the other National Governing Council members who are present in today's session. Thank you very much. Over to you, Professor Tanveer Singh.
So, so now a few words from Dr. Vishal Singla, sir, before we formally start the academic session.
Good evening, everyone, and my warm regards to our patron, Dr. Tejke Kaul, sir, President, Research Society of Anesthesiology, Dr. Naveen Malhotra, sir, our GC members, and all the delegates and chairpersons in this webinar. The success to any webinar is by active contribution of the speakers as well as the chairpersons. So I am really thankful to all the faculty who will be deliberating today. I'm sure the today's webinar, that is Youth Conclave Part 4, would be very much enriching and very much interesting. Thank you to all of the faculty who will be deliberating today, and all the best to the Youth Conclave 4. And my special thanks to Dr. Tanveer and Dr. Neha Sinha for coordinating this Youth Conclave so well. Thank you very much.
Thank you so much, sir. Now over to Dr. Neha Mishra to please carry on the proceedings.
Thank you, sir. Good evening, everyone, and a very warm welcome. Under the guidance of Dr. Naveen Malhotra, sir, and Dr. Vishal Singla, sir, we are back with the academic feast. So before going into the academic feast in detail, I would like to introduce our chairpersons. With great honor, I welcome Dr. Anil Verma, sir. He is Professor, Department of Anesthesia, Nodal Officer, Tele-ICU, GSVM Medical College, Kanpur. He is GC member, National RSACP, and GC member, ISCCM National. He was also the past president of ISA UP State. With various publications in national and international journals and with various chapters in books, his leadership and insights guide us always in the journey of anesthesia. Please welcome, sir.
Thank you, Neha.
With great honor, I also welcome Dr. Sandeep Sahu, sir, Professor SGPGI Lucknow. He's Honorary Secretary ISA UP State and past President ISA Lucknow Chapter. He has been presented with various national, international, and appreciation awards. Under his leadership, our organization not only thrived, but has set new benchmarks for excellence. Please welcome, sir.
Thank you, Dr. Neha, and ISA members and Research Society members, and the Research Society Governing Council, all the office bearers. We thanks for our active involvement and welcome all the participants who are presenting today. For your and congratulate to all of you that you are presenting on this national forum. All the best.
Thank you, sir. With great honor, I welcome Dr. Tanmay Tiwari, sir. He is Additional Professor, KGMU Lucknow, Honorary Treasurer, ISA UP State, Past Secretary, ISA Lucknow, GC member, AIDAA. His strategic insights and ability to stay focused on long-term goals have been invaluable. Please welcome, sir. Now that we have had a warm welcome, let's dive into today's session. So to ensure smooth running of presentations, kindly I request all the speakers to stick to 10 minutes, followed by 2 minutes of questions and answers. So I would like to invite our first speaker, Dr. Viral Parekh. He is consultant and anesthesiologist in Hinduja National Hospital, Mumbai. His topic would be regional anesthesia for management of acute pain in intensive care unit. Please welcome, sir.
Thank you, madam. Thank you, sir. So at the outset, I would like to thank Dr. Naveen Malhotra, sir, and the RSACP for providing us this excellent platform. Can I start my slides to share?
Yes, sir.
Yeah, Dr. Y.
I'll just stop sharing.
So the participants will be, we will tell you at 9 minutes. We'll just verbally speak that 9 minutes over.
Okay.
Right?
Right.
Mhm.
So can I start? Yes.
Yeah, sure.
So my topic for today is regional anesthesia for management of acute pain in the intensive care unit. So all of us know that pain is one of the most important and one of the most critical symptoms which we need to tackle for all our patients. as even if the patient is coming for any minor surgery or major surgery, the most important factor which he asks us as an anesthetist is that will it be painful post-surgery? So the International Association for the Study of Pain defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And this article about pain in intensive care mentioned that the incidence of pain in medical or surgical ICU is up to 50%, and inadequate management is a risk factor for emergence of chronic pain in up to 33% of the patients. Similarly, this article about regional anesthesia for management of acute pain in ICU mentioned that 70% of the patients experience moderate to severe post-op pain in ICU. And most of the ICU patients are different. They may or may not be able to communicate pain. They could be sedated or they could be paralyzed. And the traditional criteria for pain assessment, the hemodynamic signs, are poor indicators. So this article about monitoring pain in the intensive care unit mentions that we need to use other scales, like if the patient is able to communicate, we can use the numerical rating score or the VAS score. And if not, if the patient is sedated, delirious, we need to use the behavioral pain scale and the critical care pain observation tool. The recent techniques for pain evolution, like pupillometry and changes in the bispectral index or the processed EEG signals, can also help further for evaluation. Most of the patients in the ICU has pain because of the major illness, inflammation, major surgeries, body positioning because of the medical devices, post-trauma, and because of the cancer-related pain. And uncontrolled pain can lead to prolonged mechanical ventilation, increase in ICU length of stay, pulmonary complications, patient ventilator asynchrony, and PTSD. However, overtreatment is also not desirable, as it can again lead to prolonged ventilation, delirium, patient might have respiratory depression, hemodynamic impairment. Thereby, optimal pain management is the key. The hemodynamic changes because of the increased sympathetic tone. It can increase the heart rate, blood pressure, and it can cause increased myocardial oxygen demand with decreased myocardial oxygen delivery, which may further lead to myocardial ischemia. And effective pain management is done by it helps to decrease the pain intensity and thereby improve the functionality of the patient, reduces the opioid requirements, facilitates patient recovery, shortens ICU stay, and reduces the incidence of chronic pain. The modern anesthesia and the analgesia strategies, they are described as adaptive analgesia or dynamic analgesia with the help of a multimodal approach. However, for regional anesthesia in ICU, there are certain challenges like hemodynamic instability. The patient might have a coagulation disorder, presence of infectious process, concerns about risk of nerve injury. The anatomy might be difficult because of a peripheral edema, anasarca, or the neuromuscular weakness, which can mark the motor response. This concept about oligoanalgesia is very much important. As you can see in this picture, the elephant is covering himself with the umbrella, but it is not completely covered. Similar to the pain, this is an article about oligoanalgesia in the emergency setting. It's like a tip of an iceberg situation. The pain management and education is not optimized at all the centers, and it is often ignored in an emergency setting. Thereby, it can lead to viscous cycle impacting the quality of life of the patient. However, with the help of advantage of the ultrasound and the recent monitoring parameters, we can definitely provide effective analgesia to the patients in the ICU. And the desired characteristic of an ideal analgesic are it should be safe, simple, predictable, with minimal hemodynamic and respiratory disturbance, with no interference with neurological monitoring, and should be economical, and it should definitely reduce the chronic pain. And regional anesthesia definitely fulfills all the criteria. However, the time at which we provide the anesthesia and analgesia is critical. As I mentioned about the special considerations in trauma patients, we need to obtain the consent, but sometimes the patient could be unconscious or could be delirious. So that is a challenge for us. Optimal patient positioning, the resuscitation gains priority in trauma patients, and concerns regarding the masking of symptoms of compartment syndrome. However, the concept of on-arrival block has been practiced widely and so effectively in Ganga Hospital by Dr. Bala Venkat sir and colleagues. And they mentioned that with the advantages are it provides immediate pain relief and thereby improves the patient confidence in the system. It avoids the use of opioids. We can apply tourniquet without causing pain before the initial dressing is removed, and the patient is pain-free, and thereby we can do a detailed clinical evaluation of the injury. With the help of regional anesthesia, it is site-specific, procedure-specific, provides excellent analgesia, it is devoid of systemic side effects, and it improves patient comfort and safety for transport, and definitely it is cost effective. This article about regional anesthesia in critically ill patient mentions that we can use for surgical, post-surgical patients, for trauma patients, for painful procedure. As I mentioned about the non-surgical analgesia, it is sustained analgesia and sympatholysis, which is provided by the regional anesthesia in specific group of patients like pancreatitis, neuralgia, and regional pain syndrome, in which the pain is not relieved by systemic analgesia, and we need to provide a sympatholytic block, which will further lead to vasodilation, increased blood flow, and it is therefore beneficial in patient with a peripheral vascular disease, angina, and it can improve the GI circulation. As we all know that there are multiple options like epidural, the peripheral nerve blocks, and they are site specific, and it would be difficult to go into the details of each. But few words about the epidural. This was a survey which was done long back in 2002, almost 2 decades before. At that point of time in England, almost 89% of the patients received epidural for the pain relief. However, now we have progressed to site specific and more procedure specific and the distal blocks. Because the challenges with the epidural is the difficulty with proper positioning, the patient might be having coagulopathy, sepsis, hemodynamic instability. And this article about epidural is no more a gold standard from Dr. Narinder Raval mentions that for routine post-op analgesia, epidural may not be considered as a gold standard. And the reasons for decline are because of the little evidence of decrease in post-operative mortality, little evidence of decreased morbidity, the evaluation of the ERAS guidelines, advances in the surgical techniques, more of the daycare procedures, and lack of convincing evidence of the cost effectiveness of the epidural and the medical legal concerns. In that case, the peripheral nerve blocks definitely comes to our rescue. And we have definitely a cafeteria approach. We have multiple blocks as they are site specific, like for the upper limb, lower limb, for the chest wall and abdomen. But we need to avoid deeper blocks in certain group of patients in ICU. We need to definitely follow strict aseptic guidelines with proper monitoring of the patient post-block. This article mentions about the regional blocks during general anesthesia and deep sedation. There are certain myths that we should not perform the blocks in a sedated patient. It mentions that it is reasonable to perform neuraxial and peripheral nerve blocks even in sedated or anesthetized patients, and performing the procedure safely and effectively requires an adequate level of experience by the person performing it. However, we need to be cautious about the local anesthetic systemic toxicity because there is inability to assess clinical signs and symptoms if the patient is sedated, and electrolyte imbalance or the acid-base disturbances or renal failure, it can significantly impact on the effect and toxicity of the local anesthetic. Acidosis aggravates the LASH symptoms, and hypoalbuminemia can also increase the risk of LASH. There could be inadvertent confusion of infusion route, like the intravenous drug connected to epidural space and vice versa. So to prevent that, we need to have a clear, unambiguous identification of the catheter, explicit labeling of the lines, introduction of the non-interchangeable line connectors, and implementation of the organizational culture of safety and error reporting symptoms. There should be no blame game. Proper and clear-cut documentation is the key. Pre-block neurovascular examination. If the patient has any peripheral nerve injury prior performing to the block, it should be clearly documented. And the detailed explanation about the procedural complications should be explained. There should be a limb alert identifier to ensure that all staff are aware of the motor deficit which the patient might have post-block. And there should be clear-cut communication between the nursing team and the clinicians caring for the patient. So my take-home messages is RA definitely has a role in ICU patients. You need to assess the patient pre-procedure. There should be documentation of the neurological deficit, if any. You need to check for the feasibility, risk-benefit analysis should be done. Triple monitoring should be used, clear-cut aseptic precautions, and repeated assessment of the block. Watch for last and care of continuous infusion, and multimodal anesthesia should be practiced in all the patients. Thank you. We should provide pain relief to all our patients. Thanks a lot.
Thank you, sir. I request our chairpersons to please come for the discussion.
Dr. Viral.
Yes, sir.
Sorry, how I should name
Sir,
your
Viral Parekh, sir. Viral Parekh.
Okay. So you are very you use a good way of your presentation and making slides. And are you specific in your presentation that you are using these blocks for the in ICU or in generalize?
Sir, so the thing is, why I wanted to talk about is this because of the concept of the on arrival blocks, mainly in the trauma ICU, as we have seen results from multiple places that the use of nerve blocks definitely has an advantage in certain group of patients. I'm not saying that we are
It's
using
okay.
it.
What is your say regarding in septic shock patient or hemorrhagic shock patients
Sir,
having shock?
in
In
that
that
group of
patient, what is
patients,
the
we need to avoid, sir, unless and until the patient is hemodynamically optimized. And definitely the if the patient has any coagulation abnormality, we need to avoid deeper blocks. But superficial blocks can still be given after the initial resuscitation is carried out. And studies also say that even in a septic patient, if strict aseptic precautions are being taken care of, we can definitely perform the superficial blocks. So.
okay?
Dr. Viral,
Yes, sir.
what will be the criteria of selection of specific cases in intensive care in your study?
Sir, so as I mentioned, if it's a post-surgical patient, so if it's whether it's a trauma patient or an elective surgical case, so if the patient has received a block uh, intraoperatively, or if he has not received the block, if the patient has not received, then whether it is feasible. So if the patient has any complications associated with surgery of that, or if there is a any prolonged ICU stay, which could be a possibility, then we might put a peripheral nerve block catheter. Or in definitely in trauma patients, if the patient like how what we are doing is giving a femoral nerve block, or we can do a PENG block, so that the patient has a good hip analgesia before the patient is being taken up for the surgery. So definitely, if the patient is in ICU, we can provide the blocks.
Okay, so primarily you are practicing all those blocks for the trauma patients,
Yes, sir.
uh, primarily. So if you place the catheter and there is a patient of a polytrauma patients, so what are the preference of your site selection for those trauma patients? As is there any list which you have made? Okay, first this site to be covered first, and then this to be second. Which are the how do you prioritize your blocks in polytrauma patients?
So definitely, as we all know, the distal limb blocks like the intraclavicular catheter is one of the safest site, because the catheter chances of catheter discontinuation or the catheter removal, accidental removal is less. So that is one of the preferable for the upper limb blocks. Then for the lower limb, the femoral and the fascia iliaca are one of the most commonly used, and definitely with a lower chance of complications. For other peripheral blocks, like for polytrauma patients with catheter, I would definitely not recommend for the interscalene or a supraclavicular catheter. And lower limb also, we can put a catheter for the femoral or the fascia iliaca. But the deeper thing, like in patients who definitely at the joints, we would try to avoid the catheters. And not the epidural, obviously, we would try to avoid.
Fine.
Okay, Dr. Parekh, excellent presentation. I would just like to ask, how often do you practice in your own setup?
So in our setup, sir, usually post-op patients, we provide some sort of a block or a continuous catheter. So that continues the regimen in the ICU. If not, then we are giving up PCA pumps. And for trauma patients, definitely before taking the patient for the procedure, some sort of a block we are giving. So most of our patients in our setup are elective cases, but if any emergency patient comes in the casualty, we would definitely try to do the block.
Okay. Thank you, Dr. Parekh. Well done.
Thank you, sir.
Keep up the good work.
Thank you.
I think we can move on to the next.
Yes, sir.
participant.
Yes, sir. Our next speaker would be Dr. Yash Mehta. He is consultant anesthesiologist in Indore. His topic would be fetal surgeries and anesthesia implications. Dr. Yash Mehta,
Yes, ma'am. Thank you, ma'am. Am I audible?
kindly share your presentation.
Yes, ma'am. Is my screen visible?
Yes, screen is visible, but you have to go on the full screen mode. Yeah.
Is it visible?
Yes, Dr. Yash. Good to go.
Okay. Very good evening, everyone. I am Dr. Yash Mehta from Indore, working at CARE CHL Hospital. I would like to thank Team RSSCP for bringing such a nice platform. I will start my presentation. My topic of presentation is fetal surgery. Where do we stand? Where do we as an anesthetist stand for fetal surgery? Now, in upcoming slides, we will be seeing about the evaluation, current practices, and future of the fetal surgery. So, first of all, we will be seeing the evolution of fetal surgery. Just a minute. So, Sir Michael Harrison is the father of fetal surgery. He did first fetal surgery at UCSF in 1981. Before that, first tissue biopsy and blood sampling was done by Carlo Valenti sir in 1972. After that, in era of 1990s and 2010s, fetal minimal invasive procedures has come, in which twin transfusion syndrome, laser ablation was there. After that, procedures for spina bifida repairs was there. SAFER trial was done for that, and MOMS trial for meningomyelocele study was done. And then this new era of AI and robotics assisted fetoscopy has started, and this is the future of fetal surgery. Now, in current practices, our aim is to interrupt the in utero progression of an otherwise treatable condition. Now, how can we classify fetal intervention? It is based on invasiveness of the procedure, can be divided in three categories like non-invasive, minimal invasive, and invasive procedures. Invasive procedures are those in which laparotomy and hysterectomy is required. Exit procedures, which is also known as OOPS procedure, is there. Mid-gestational open surgeries are there. For minimal invasive mid-gestational procedures, fixed IT and fitendo surgery are there. Non-invasive procedures are USG and MRI based. Sorry, my slides are not moving. Why is this not moving? Slides are not moving. Just a minute.
You can restart and come on the next slide directly.
Yeah. Okay. So indications of the procedure are minimal invasive procedures, which are done for spina bifida, aortic pulmonary stenosis, valvuloplasties are done. For twin transfusion syndrome, laser ablations are done. And for congenital diaphragmatic hernia, tracheal balloon occlusions are done. For obstructive uropathy, valve ablations are done. Invasive procedures, these are usually done for meningomyelocele repair, for sacrococcygeal teratoma excision, and for intrathoracic mass excisions. Now we will be looking for some procedures which are usually done. This is the, as the picture is showing, this is a exit or OOPS procedure. These are done mainly in fetuses with known airway compromise. As picture is showing, opening is made on the midline of the anesthetized mother's abdomen and uterus. Then comes the exit. Exit is the baby is partially delivered through the opening but remains attached by umbilical cord to the placenta. And after that, endotracheal intubation is done. Once the exit is complete, the umbilical cord is clamped, then cut, and the infant is, after that, infant is fully delivered. Then later on, remainder of the C-section proceeds. Minimal invasive mid-gestational procedures. It includes of fixed IT. Fixed IT is fetal image-guided surgery for intervention or therapy. As picture is showing, we usually USG or MRI guidance is taken in this. we have to directly visualize umbilical cord, and we have to visualize umbilical vein. We have to directly inject corticosteroids or surfactants or any other treatment through the umbilical vein. It is percutaneous or fetos. Guidance. Now, what is fetus plus endoscopy, which combines to form fitendo. As picture is showing, fetal endoscopic surgeries is typically done percutaneously using a fiber optic camera and tiny surgical tools, but sometimes it may require mini laparotomy. What is feto? Feto is fetal endoscopic tracheal occlusion devices. These are placed in trachea. Feto is a minimally invasive procedure where the small balloon is inserted into the fetal trachea to block the airway. Endoscope is used to place a small detachable occlusive balloon in the fetal trachea. The fetus continues to grow through the rest of gestation with the reversal of disease process. After some time, with a second fetal endoscopic surgical technique. Now, what is the function of feto? Feto improves type 2 pneumocyte functioning, and it may also increase surfactant production. So, mid-gestational open surgery, as picture is showing, it involves a maternal laparotomy and hysterotomy. The fetus is exteriorized for procedure, and then after the procedure is complete, the fetus is placed back into the uterus, which is closed. The fetus continues to grow through the rest of gestation with the reversal of disease process that prompted the fetal intervention. Now, there are a lot of risk factors associated with fetal surgery, which are enlisted here, like maternal risk and fetal risk. Now, up till now, many questions might have arisen in your minds, like does fetus experiences pain, or does fetus remember, or how can we replace amniotic fluid after open surgeries? So we will be looking these questions. So the first question is, does the fetus experience pain? So my answer is yes, but after 20 weeks of gestation. Fetuses are unlikely to experience pain before 20 weeks of gestation because the cortex requires additional growth and development to establish the extensive neural network or pathways to other CNS structures. By 6 to 10 weeks, pressure, temperature, and vibration senses appears. And by 10 to 17 weeks, peripheral sensory nociceptions appears. And after 19 weeks of gestation, reflex withdrawal from a noxious stimulus appears. So the next question is, does the fetus remember? Answer is yes. Fetus is capable of forming memories, mainly to sound exposure, which can be of short term, like from 10 minutes to 4 weeks, which appears by 30 to 32 weeks of gestation. So next question is, how can we replace amniotic fluid? Amniotic fluid can be replaced by a process known as amnioinfusion. This can be done transcervically or can be done percutaneously. In these, amnioports are introduced, which are connected to transducer and pressure catheters. After that, infusion of warm ringal lactate with antibiotics at the rate of 250 to 500 ml of solution over 20 to 30 minutes, or to maintain AFI at 8 to 12 centimeters. So the fetus as a patient, what are our goals? Our goal is to prevent fetal movement, adequate pain relief, and inhibition of circulatory stress response with fetal amnesia. How can we do that? For prevention of fetal movements, we can use vecuronium in doses of 0.3 mg per kg IM or 0.1 to 0.25 mg per kg IV. For adequate pain relief, fentanyl, intramuscular fentanyl at doses of 5 to 6 mics per kg can be used. and for inhibition of circulatory stress response and fetal amnesia, midazolam, IV midazolam to mother can be given. So how can we give these drugs to fetus? This can be transferred from mother, maternal circulation, or we can give directly to the umbilical cord, intravenously to umbilical cord, USG guided. So
Dr.
what
Yash,
are
1 minute
fetal?
left.
Okay, sir. These are some of our fetal anesthetic consideration. As a mother, as a patient, what are our goals? Uterine relaxation, tocolysis, analgesia, and maternal comfort. These are some of the maternal anesthetic consideration. All considerations are similar to pregnant female. We have to keep that all in our mind. So what are the advantages of fetal surgery? In utero environment supports rapid post-operative healing fostered by fetal growth factors. Infections are combated by passage of maternal assistance, and medical agents given directly to fetus have greater efficacy and reduced doses. So these are some new researches. Remifentanil produces improved fetal immobilization with maternal sedation and only minimal effects on maternal respiration. Continuous fentanyl infusion with midazolam provides acceptable maternal analgesia and sedation. So what is the future of fetal interventions? There has been an observation that the fetal incisions heal without scarring, and it has provided new insights in biology of wound healing. Fetal tissue seems to be biologically and immunologically superior to transplantation and for gene therapy, and can be used for hematopoietic stem cell transplantation also. So what is my take home message is prenatal diagnosis improves perinatal care, and future focus on multidisciplinary fetal surgery centers with dedicated anesthetic and surgical expertise. So we should be focusing on this branch. Development of newer, more potent tocolytics to control preterm labor, and developing more targeted and safer anesthetic agents, both for mother and fetus, with more specific pain biomarkers. And we have to be focusing on improved techniques for fetoscopic visualization and artificial womb technology. These are some of the references of my presentation. And thank you.
Dr. Yash,
Yes, sir.
besides the technical glitch, but your topic is very innovative and new for the anesthetist. So what? And I must congratulate you because this is not a routine work that people usually do. So what is your experience in this field, in this fetus as a patient, and your work as anesthesia for this exit and other procedures?
So right now I am working at Care CHL Indore. We does not have any exposure for such brands.
Okay. But
Because in India, there are only 4 to 5 centers which are performing these procedures. It is mainly performed at Kochi and Delhi.
I know it's more work done in Western world nowadays. But
Yes, sir.
now the science is emerging, but you presented very well the concept, and this is a new concept. But I want to know what that you are practically doing, or this is your review experience about this topic.
Just experience, sir.
Okay.
We are not
But you
performing.
nicely described because this is a future coming surgeries.
Correct, sir.
Yeah, because fetus now is a patient, and we are treating here because we have fetal medicine and SGPGI. So few of procedures we do, and it's really challenging. It's really challenging when
Yes,
you are
sir.
doing a neonate, but fetus, it's beyond the limit. So
Yes.
congratulations for nice presentation.
Thank you, sir.
Shall we go ahead, sir?
Yes, Neha, we can.
Okay. So the next speaker is Dr. Soumya. She is Assistant Professor, ESIS Medical College and Hospital, Patna. Her topic would be nitrous oxide sedation. Dr. Soumya?
Good evening, ma'am. Yes, ma'am.
Please share your slides.
Yes, ma'am. Okay. Good evening to all the respected dignitaries and a heartfelt gratitude for giving us such an esteemed platform to present. So, I'm Dr. Soumya Singh, working as Assistant Professor at ASIC Medical College, Patna, and I will be talking on the topic of nitrous oxide sedation. So, to begin with, I bring you greetings from the city of ancient glory, that is Patna. Starting with a little bit of history, basically, in the year 1772, Joseph Priestley was the first person who discovered nitrous in his book Experiments and Observations on Different Kinds of Airs, followed by Sir James Watt, who in 1794 discovered a delivery device for nitrous. In 1800, Humphrey Davy was the scientist who discovered possible utility for elevating pain during surgery using nitrous. In the following year, in 1844, Sir Gardner Quincy Colton was the first person who carried out a first public demonstration for tooth extraction using nitrous. So by 1870s, nitrous oxide had become a staple in dental anesthesia, and by 1930s, it had almost replaced chloroform as a drug of choice for labor analgesia. So these are a few properties of nitrous which we all are aware of. Among these, the most important for us as anesthetists is of course the mean alveolar concentration, which is almost 105 for nitrous, and the blood gas coefficient, which is 0.47. Moving over. So why nitrous? Basically, in the operating room, the nitrous oxide has low solubility in tissues and it promotes rapid elimination and rapid recovery. Also, nitrous oxide, as we know, is odorless and it does not cause irritation to the tracheobronchial tree. Further, faster uptake pharmacokinetic profile allows rapid distribution and elimination due to the second gas effect. So the first trial which was ever conducted for nitrous was the Enigma trial. To be broad terms, it meant the evaluation of nitrous oxide in a gas mixture for anesthesia. It was conducted in the year 2007 by Miles et al. Basically, it included around 2,050 patients. Patients who are undergoing major surgeries were divided into two groups. One group who were given 80% oxygen with 20% nitrous oxide, and another group who was given 70% nitrous oxide and 30% oxygen. The primary outcome that they wanted to study was the length of hospital stay. Along with that, the secondary outcome also that they studied was the length of ICU stay and post-surgical complications within 30 days of the surgery. And unfortunately, the main findings in those studies were very dismal. There were increased rate of major complications like myocardial infarction, stroke, and pneumonia. Also, the patients who were given nitrous had severe PONV, that is post-op nausea and vomiting. So later, exactly 7 years later, the same authors countered their own findings in their next multicentric randomized study, and they called it the Enigma 2 trial. This included a large number of patients, around 7,112 patients, again divided into two groups, one group with nitrous, another group without nitrous. But the common thing here was that both groups had patients with known or suspected coronary artery disease. Here, their main primary clear outcome that had to be assessed was about cardiovascular complications and death. Along with that, secondary outcomes like surgical site infections and PONV were also studied. Here, to the relief of the authors, the main finding that was found that risk of death at 1 year, cardiovascular complications, or the surgical site infections is not high in the nitrous group. Also, again, the risk of PONV was less by 1/3 in patients who were not exposed to nitrous oxide. This is the actual Enigma True trial, which was published. So now, how does nitrous oxide act? It basically affects the postsynaptic targets where it blocks the NMDA receptors. The analgesia is mainly due to the inhibition of T-type calcium channels. Another study was conducted. It was a meta-analysis which revealed that the risk for PONV increases if the nitrous is time dependent. That is, lesser the time of exposure, lesser will be the PONV. So low risk if exposure was less than 1 hour. Also, we all know general anesthesia, if supplemented with nitrous, provides a deeper plane of anesthesia, reducing the risk of awareness, which is an important factor for us as anesthetists. Again, in 2014, the same year of the Enigma 2 trial, 27 articles were studied which included 10,317 patients. They were studied primarily for post-op nausea vomiting 24 hours after surgery with or without the use of nitrous oxide. Payton and Wu were the authors who identified that the risk ratio for PONV increases 20% per hour after the first 45 minutes of exposure. Duration of less than 1 hour has minimal effect on PONV. This was the original article that was published expressing their risk ratio. Another field where nitrous will be is usually an advantageous gas for us is pediatric patients. It is useful in obtaining intravenous access. Also, better analgesia and anxiolysis for minor procedures like fracture reductions, foreign body extractions, which is very common in the pediatric group, lumbar punctures, bone marrow aspiration, laceration repair, surgical dressings, and conducting pulmonary endoscopies. So these are a few studies which I have tabulated, which included pediatric patients only. So the first one was conducted by Babel et al. In the year 2008. It included 762 children of the age group of 1 to 17 years. Basically, they studied the depth of sedation and incidence of adverse effects with various concentrations of nitrous oxide. And their main finding was that nitrous oxide in high concentration and continuous flow was found to be a safe agent for procedural sedation. Then the same group of authors in the year 2010 conducted another study in which they included around 2,002 patients of the same age group, 1 to 17 years. And here the sedation practices were studied and the associated adverse events were profiled. So the main finding here was that nitrous oxide was used in majority cases and incidence of serious adverse event was low. Serious adverse events meaning desaturation, seizure, and chest pain. Another study was conducted by Brown et al. In 2010. This study was conducted on a very small number of children, around 40 only, of the 3 to 9 years. Basically, this was to describe the particular device, which is called the pedisedate device. It is used in foreign countries where it has got a nitrous oxide delivery system which is combined with an interactive video or a game. It reduces the children's behavioral distress. And it is obviously an effective system of procedural sedation in children. Then in the next year, in 2011, authors Egbaum et al. Conducted a study where they compared to find out if oral midazolam or 50% nitrous oxide or 10% nitrous oxide along with lignocaine or prilocaine ointment is most effective in gaining access in difficult cases, which is a very big challenge us as an anesthetist. So this study included around 90 children of the age group of 5 to 18 years. And the finding was that 50% nitrous oxide resulted in an improved rate of IV access, a shorter procedure time, and a better experience for the child. These are the article references that I had already quoted. We can move ahead. This is the device that I was talking about. This is the pedisedate device. It has got a small mask and a connection to a small screen, which can be used to play videos or can be installed with games. Of course, it has got an oxygen port also, just in case we need to supplement oxygen along with the nitrous. So another field where nitrous oxide has been used since times immemorial is labor analgesia. It is used for labor analgesia in UK since 1930s and in the US since 1970s. Basically, what acts in the favor of nitrous oxide is rapid onset, rapid offset, anxiolysis, and to some extent analgesic properties. So there are two studies which I have quoted. One was conducted by Leong et al. In the year 2000, where 123 women in early labor who were offered epidural analgesia versus nitrous oxide, but the maternal satisfaction was better with nitrous oxide assessed on the day 1 of postpartum. In another study conducted by Richardson et al. In 2016, this was a retrospective analysis to assess pain relief and overall satisfaction in a wide group of patients, around 6,507 patients who delivered vaginally, either with nitrous oxide or neuraxial labor analgesia. So according to this study, also patients who received nitrous oxide alone had a better analgesia. This is the article that I had quoted. So this was the original study in which 6,507 patients were included, and all the patients delivered vaginally, but either with the support of neuraxial blockade or with nitrous oxide, and maternal satisfaction was better with nitrous oxide. So a newer aspect of use of nitrous oxide is coming up in psychiatric disorders, where it is being used to treat treatment-resistant major depressions. It is basically acts as NMDA receptor antagonist. It is also being studied in cases of PTSD and patients with his family history of alcohol abuse.
Dr. Soumya, you have 1 more minute.
Right, sir. So this is the study that I'd like to quote regarding the psychiatric effect. It was conducted by Nagel P. et al. It was a blinded placebo-controlled crossover trial. 20 cases of treatment-resistant depression were randomly assigned to 1 hour, and they were given an inhalation of 50% nitrous oxide and 50% oxygen or placebo. And their endpoint was checked on the 21-item Hamilton Depression Rating Scale. So the results that were very favorable were the depressive symptoms improved significantly after 2 hours and 24 hours in these patients. This is the actual article that was published. And of course, if we use nitrous along with our agents, the cost comes down. And in economic country like India, I think cost cutting is the major factor that we face in all our hospitals, whether be it government setup or private setup. So yeah, all said and done, we cannot ignore the fact that among a lot of allegations and controversies, nitrous oxide still remains a widely used agent in the past, present, and will be in the future. Thank you, and thank you for your patient listening. And this is just to depict that these are all my primary views, open to constructive criticism and discussions. Thank you.
Wonderful, Soumya. You have again probably you have put the utility of nitrous oxide again, because otherwise it has gone out of our anesthesia practice,
Right.
and most of the places we keep on using air and oxygen mixture, and we try to avoid nitrous, but definitely
Yes,
nitrous
sir.
has so many important roles, what you have already discussed. So because the most common fear with the nitrous oxide is the distension of the air cavities as well as the PONV. So,
Right.
as per the so many studies you have quoted, and you have also told that the incidence of the PONV is relatively increased. So, what will be your suggestion to just be free about the fear of this PONV? What are the suggested treatment?
So, as a treatment protocol, pre-op measures should be taken to prevent PONV. Then, anyways, in the post-op, we give them adequate drugs to reduce the effects of PONV. If the patient is in ICU, then also it should be taken care of. Plus, how much ever possible, we should try to reduce the surgical duration and the exposure to nitrous, which will, in case, reduce the effect of PONV also on the patient.
Okay. Uh, so as per your suggestion, all the studies which has been quoted, the nitrous oxide would be a very good drug to be used for the pediatric patients. So
Right.
how many times, how frequently you use nitrous oxide for the pediatric interventions?
So we usually use it when we are stuck with the children whom it is difficult to gain an IV access. We have been using it in our hospitals along with a little bit of sedation. We try to calm down the child with nitrous and then secure an IV cannula, and then further we proceed with the cases. Uh, Almost every week we have some pediatric OT, so we have been using it there
So
quite frequently.
what advantage you feel that rather going for IV sedation to these patients or IM sedations with analgesia to these patients, the nitrous oxide would be beneficial. What is your take-home message and
Uh,
recommendation?
Right, sir. So usually with the IV, if we are completely in loss of an IV access, so then it is always better. Compared to IM also, what we have seen, the results of using nitrous is much better to calm down a irritable or crying child in the OR. When we already have an oxygen backup and we have all the monitors and we are actually safe to carry out that. So we usually practice with the nitrous only, sir, rather than going with for an IM.
Fine. And Dr.
Because
Sahil,
IM again,
yeah,
sorry, sir.
okay then.
Because IM again causes pain, which again further irritates the child even more, sir. So that becomes an issue.
Okay, fine.
Okay,
Dr.
Dr.
Tanvin,
Soumya,
Dr. Sahil
what
can
is your take on the GWP of nitrous oxide? Global warming potential of the nitrous oxide.
Right, sir. I know that is a very concerning factor, but then, sir, I don't think it is right to blame nitrous solely for it and ignore all the other factors and ignore all the other drugs and gases that we use in the OT. So I accept that there is a lot of burden on the pollution itself, I mean, on the environment itself.
Mm.
But then, sir, that cannot be solely blamed on the nitrous oxide. So I would
And
say that it should not be
all
completely
the recent
diminished.
guidelines, as per the societies, have highlighted that the nitrous use should be reduced. Yeah, and the
Right,
medical
sir.
gas pipelines should be abandoned of the
Right,
nitrous,
sir.
and only small cylinders of nitrous should be used at the patient bedside if needed. So
Right, sir.
there's a growing demand that the nitrous use should be minimized.
Right, sir. So that
Okay.
is why I wanted to discuss this at this platform so that I can get better views on this, because I feel nitrous should not be completely disregarded. It should be used, but in adequate amounts, like any other
Definitely.
drug that we use in
Definitely.
anesthesia.
We should always
Dr.
use
Soumya?
as required. Thank you, Soumya.
Yes, sir.
Thank you.
Thank you, sir.
Nice presentation.
So,
Thank you,
Dr.
sir.
Soumya, you nicely reviewed, I will say, use of nitrates
Right, sir. Right,
and the
sir.
trials. And do you, in your OT, do you have the air and nitrous both, or do you have only nitrous?
No, sir, we have air and nitrous both, sir. And we use it routinely in all the cases also, sir.
It should definitely it should be used as per indicated,
Right,
but anything is not obsoleted. We are still using
Right, sir.
scoline. We are still using ketamine in
Right,
India.
sir.
Yeah.
Exactly,
Okay.
sir.
Thank you.
Thank you, sir.
Thank you, sir. Shall we go ahead, sir?
And next, please, next one.
Yeah, okay, sir. So the next speaker is Dr. Ira Dhawan. She is assistant professor in PGI Chandigarh. Her topic would be the whole kit and caboodle of EZ blocker. Dr. Ira?
Yes, good evening, everyone. Are my slides visible?
Not yet.
Okay.
Yes.
Okay, is it visible now?
No.
Okay. It was before. All right.
Not right now. Yes.
Okay. I'll switch off my video in case the bandwidth helps in present. Am I audible?
Yes. Please go
Can you
ahead.
again switch off your
Okay.
video? I think the connections are not that great at your end.
Okay. Okay, so good evening, everyone. I'll be presenting on the whole kit and caboodle of the EZ blocker. So I'll give a brief overview of EZ blocker and how we can use it even for novel users. I have no financial disclosures or conflict of interest. So this 2009, the first clinical use was described by Hubert E. Mangroep. It was invented by Peter Jong Jo Wai from Amsterdam in Netherlands. And in their initial presentation, they had originally named it as a twin blocker, because as we can visualize here, that the distal tip, the two limbs of this EZ blocker, they are exactly similar. Therefore, the name twin blocker. So to be familiar with the EZ blocker, which is available, this is a 75 centimeter long catheter, which is 7 French diameter, and two distal limbs, which can nicely abut on the carina on the two sides, and once inflated with one of the pilot balloons, can block the desired site for one lung ventilation. So this blocker is, as the name suggests, easy to use vis-a-vis the other blockers which are available, as well as the DLT, and hence I'll be talking on this. Apart from the two limbs, it has 4 lumens. These are the two pilot balloons which are color-coded for each balloons, and also there are 2 egress ports which communicate to these tip of the lumens, which are entering into either bronchus for either suctioning or providing oxygen. This bronchial blocker comes adapter where tracheal tube, this ventilator, you can insert your blocker through this port and you can insert your fibroscope through the side port. So for deployment essentials, you require a minimum of 4 centimeter between the endotracheal tip and the carina, because the distal two limbs, as we saw in this previous picture, they are 4 centimeter in length. The caution that these ET tubes cannot go in sizes lesser than 7 mm internal diameter. So its use is FDA approved in adults. So you gently advance this to bifurcate at the carina. Small video shows I do it now. The protective covering is removed, and now we are checking the pilot, inflating the pilot balloon to check the distal balloons which will be inflating. Both the balloons are being checked, and you can see this long flimsy catheter which will go, and this is the multi-port adapter with which this EZ blocker comes. So you fold it and insert it through the EZ blocker labeled here. It mentions EZ blocker. You insert the Y-shaped distal end here, and so this port we can connect the fiber optic and connect the ventilator here, and this goes with the endotracheal tube. This is the cap which, when locked, will seal this and will not to move further and move from its position. So, sorry. Play. Just a second. I think there are 2 videos which are not playing in this. Can I end show and play it again? So in this, you can see that the multi-port adapter is attached to the endotracheal tube, and the EZ blocker is easily inserted.
Either your presentation is not visible.
Not visible.
You have closed your presentation.
Okay, sorry. Oh, just a second. Sorry. Share. Visible?
Yeah, it's full screen. Can you can start now. You can play the video.
Okay. Yeah. All right. So now we can see that this EZ blocker is being introduced to the port. The ventilator is connected on the side, and this is on the endotracheal tube. And it took me hardly less than 10 seconds to insert the EZ blocker. I just go gently till I feel the resistance and I lock it. And then you have to confirm through the bronchoscopy, and you can visualize on the right side the image that my fibroscope is being inserted. You can see this flimsy catheter, some secretions which are being sucked out for poor view. And after this suctioning, what you're trying in, and you see this inflated balloon on the right side and deflation on the left side. So you know that isolated the right lung and we are ventilating the left lung. So this is how a normal EZ blocker nicely fits on the carina. So we had another patient. Now again here the ventilator is being connected on the side, and after insertion of the EZ blocker, we are forming fiber optic. And what we see in this patient is that the EZ blocker has gone onto the left side and there is nothing on the right side. So both the Y limbs are now on the left side. So how do we troubleshoot such a situation? So troubleshooting malposition, if it is improperly placed, it is recommended that you withdraw the bronchial blocker slightly and then advance gently. Or the other method is you minimally inflate the right bronchial cuff to open up the Y shape of the blocker. So it will be separated and it will abut onto the carina easily. This was a novel method which was described Journal of 2024. External tracheal manipulation. They're like, don't move the tube, don't move the blocker. Anyways, just withdraw the blocker. And then under fiber optic vision, you just externally manipulate your carina till it comes in between those two limbs of your EZ blocker. So this is another way which can be performed. And other second troubleshoot, apart from malposition, what we can face with EZ blocker is the delayed deflation time. So you ensure that you have removed the cap for the egress, proper egress of the air. Deflation begins immediately after positioning because it takes some time because of the smaller lumens. And in spite of that, if deflation doesn't occur, I always prefer to do suctioning along with it. A rare complication, that is expansion of the non-dependent lung, has also been reported in a case series where 4 cases were reported where they saw that both the pilot balloons got inflated and the patient had high peak airway pressures, hypoxemia, expansion of the non-dependent lung. So when they sent a complaint to the company, they found that with the saline test, the leaking from one cuff to the other was visualized with their contrast. Another rare complication which can occur is the entrapment of the EZ blocker in the Murphy's eye of the endotracheal tube. That is rare. Again, management method would be withdrawal and then reinsertion of this EZ blocker. And another case report was on the risk in an irradiated bronchus. So if you're doing in any carcinomatous patient which is post chemoradiotherapy and the tissues are fragile, this sharp tips can even perforate. Guide is very important, but in spite of this complication can occur although you're using a fiber optic in these patients. So
Last
take
1
home
minute
message
left.
for EZ blocker is that you use, so you use your endotracheal tubes not more than 7 mm, have at least 4 centimeter distance between the distal tip of the ET tube and the blocker, and master the troubleshoot maneuvers, recognize rare but serious complications. Thank you.
Thank you very much. I request our chairpersons to go ahead with the discussion.
Dr. Ira, you have mentioned that EZ blocker, and it
Yes,
is a
sir.
blocker where we insert the catheter is being proceeded to both the bronchus simultaneously. So, what do you feel the advantage of this catheter over the conventional catheter, which just goes into the one side of the lung?
Yes, sir. So the
Because
only advantage which it
because you
has shown is
mentioned
the
few
stability.
complications, either both the ends goes onto the one side, or it might have gone through the eye of the your endotracheal tubes.
Yes.
So what are the advantages you feel with
Yeah.
this catheter?
So first and foremost, personally, I have not used other bronchial blockers. I have used EZ blocker. I find it very comfortable and easy to use, as the name suggests. The literature also suggests the improved stability of this bronchial blocker because it abuts onto the carina. It straddles onto the carina, which is considered to be important for its positional stability, vis-a-vis other bronchial blockers, which can get displaced once positioned, even through fiber optic.
Right. Dr. Tanmay and Dr. Sahu.
Dr. Ira.
Yes, sir.
Okay, so you mentioned about the EZ blocker. So can
Yes,
you
sir.
tell me what do you routinely practice with the EZ blocker, or do you use DLTs, or do you
Yes.
require a set of patients in which you use EZ blockers, and you have categorized your practice in the DLT and the EZ blockers? Can you highlight few of the cases in which you routinely use the EZ blocker?
Sure, sir. So my experience is very little for the past 3-4 years. I saw it first at CMC Vellore, and since I'm here as a faculty in PJ, I've been regularly using EZ blocker. I've used DLT in the initial 5-6 cases of thoracotomies. But here now, whenever I get a lung case, I prefer using a EZ blocker. Only cases which I am concerned of avoiding EZ blocker is where I anticipate communication between the bronchus and the lung where a lot of secretions or blood, massive bleeding is anticipated, or a lot of purulent secretions are anticipated for reason that the suctioning at times becomes difficult with that small lumen of that EZ blocker. Although it is possible because you inflate the other blocker and then you do the suctioning through that port. Apart from those cases, simple cyst cases, even for minimally invasive, we have done few cases of minimally invasive also using a bronchial blocker.
Yeah, what drawback do you see if your easy blocker is not functioning well during the time of surgery? Because you have already used a single lumen tube, and many a times it happens that your easy blockers doesn't give a satisfactory response to the surgeon. And what is your plan when the EZ blockers doesn't functions as it is supposed to function? What is the thing which you actually do?
So, as of now, that has been a fear because once I'll tell you my personal experience with two of the cases. One case is the surgeon said the lung is not deflated. So I was surprised because I confirmed the position bronchoscopically as well. And I had opened the egress port also since the beginning of the surgery so that it deflates adequately. But then unfortunately, the surgeon wasn't happy with it. So I did a bronchoscopic and I was worried what next to do. So only thing which I did was simply attach the suction to that port and the lung got deflated. That was one session which I faced was an issue. The troublesome. Another was I did face high peak airway pressure problem with hypoxemia and desaturation to our patient. In that case, I was worried, although our case was managed by deflation and reinflation of the bronchial blocker. But the other opportunity, you should have an additional EZ blocker backup to exchange over the same. Although change of tube and change of DLT is possible if the position is supine.
So my last question is, what would you prefer if everything is normal, the airway is normal, your DLTs are available? So would you prefer a DLT or would you go for EZ blocker? There is no difficulty in it's a normal air.
EZ blocker.
So you are going to go for the EZ blocker?
Presently, I'm using EZ blocker. Yeah. Presently, I'm doing that, sir. We need more literature to have some. And with my present experience, I'm happy with the usage of EZ blocker, sir.
Okay. Chalo. Thank you.
Dr. Longest duration easy blocker you have used in which case? Your personal experience, the longest duration for easy blocker you have used?
4 to 5 hours. So minimally invasive surgery for a ASD we had done.
Okay. So we are doing here robotic cardiac surgeries in SDPGI, and we have to use. You already know that even for CABG we are doing the robotic with the DIMA and RIMA, and it takes time. So sometimes in the initial it goes longer, and sometimes there are difficulties are higher when you are doing longer duration. Nice presentation, your video and all that. Thank you.
Difficulty regarding what, sir? The deflation part?
Yeah, it's okay. I am just want to know how longer you have.
Yeah, sure. Thank you, sir. Yeah. Thank you, sir.
Thank you, sir. Shall we go ahead?
Yeah, next, please.
The next speaker is Dr. Yogita Agarwal. She is consultant in Ethel Raheja Hospital. Her topic is Dilemma of Anesthesiologist for ASD Patients Coming for LSCS. Dr. Yogita?
Yes, ma'am. My slide is visible.
Yes, it is.
Okay, shall I start?
Just make a PowerPoint presentation.
You have to make it full screen.
Start the slideshow, please.
I have slide. Is it a slideshow now?
You can see the option there. Yeah.
Is it okay now?
No, it's not coming in the slideshow. I think we just try and share it again.
Okay.
Unshare and then share again.
Is it a is it a slideshow right now?
No, it's not.
I'm doing the slide share only. I don't know why.
You can quickly share the slide with me. I'll share on my end. We can.
Okay. Okay, sir. I will do that.
Meanwhile, I think we can go for the next presentation to just save our time.
Okay, thank you.
So our next speaker is Dr. Preeti Dher. She's consultant anesthesiologist in Dher Hospital and PG Institute of Ophthalmology, Bhiwani. Her topic is green anesthesia. Dr. Preeti, you're there? Dr. Preeti?
Yeah, she's there. I can see her video. Can you unmute yourself, Dr. Preeti? Yeah, please share your slides.
Hello, good evening, everyone. Thank you, RSACP, for giving me this opportunity to speak on this platform. I'm very grateful for this opportunity. I'm Dr. Preeti Dheer, consultant anesthesia at Dheer Hospital and Postgraduate Institute of Ophthalmology, Bhiwani, Haryana. So my topic for the today's presentation is green anesthesia, strategies for environmental sustainability. Oh, sorry. So, what is the green anesthesia? Green word here itself specifies that it is for the environment friendly and sustainable environment. So these are the specific measures we anesthesiologists can contribute to a consistent and sustained reduction of carbon dioxide emissions and minimize the negative ecological implications associated with anesthesiology and critical care or branch. So, why the need for green anesthesia arised? So these are due to climate change and global warming due to human activities. The healthcare system itself is responsible for the significant emissions of greenhouse gases, owing to 4.4% of global greenhouse gas emissions. Surprisingly, among the healthcare workers, we anesthesiologists are the most responsible who are generating these greenhouse gases rather than our physician and surgeon friends. So that's why green anesthesia is such a hot topic today, and it is very important for us to know and be aware about the green anesthesia. And also we are at risk of some health risks like neurological disease, dementia, reproductive disorders like nitrous oxide cause teratogenicity, fatigue, and headaches, myalgias, etc. These are the risks to every healthcare worker. But we, as the anesthesiologist, we are contributing to these greenhouse gases. So the need of green anesthesia has arisen. Actually, what is the greenhouse effect? Actually, starting from the basic, greenhouse effect, it is a natural phenomenon. It is just that the sun radiations coming from the sun, some of them are reflected back by the atmosphere to the space, some are absorbed, and some are reflected from the earth's surface to the atmosphere. So in natural process, some sunlight absorbed at the surface that heats the earth's environment, and it increases the temperature of earth that is suitable to life. But because of these greenhouse gases which we are producing, human activities, earth's temperature has increased to such a high level that it has become inhabitable. There has been weather extremes, heat strokes, and most of the problems are coming. So when the Earth's surface is heated up, it releases the infrared radiation, which are again trapped in the atmosphere, and heat trap is there. So what are these gases which are producing this effect? 80%, almost 80% is the carbon dioxide, which is responsible. 11% is the methane, 6% is the nitrous, and 3% are these chlorofluorocarbons and haloalkanes. I'm sorry, Dr. Somya, but I would contradict your statement of using nitrous in sedation for OT sedation, nitrous in the OT sedation. So I'll be speaking against your words. I'm so sorry for that. What are the environmental impacts of these volatile anesthetics? These volatile anesthetics which we use in our practice, like isoflurane, CO, desflurane, they are very potent greenhouse gases which absorb the infrared radiation released from the heated earth. They trap the energy inside the atmosphere. And what is the most important factor is that volatile anesthetics is not their emission is not regulated, as these gases are deemed as the medical necessity. There is no regulation how much we are producing, or the hospital, there is no mandatory guideline on these emissions. So this is also need of the hour to regulate, and how can we make it sustainable. So our anesthetic gases, they have high global warming potential, though they are responsible for 3% of the gases, but their global warming potential is very high. And how do we calculate this global warming potential? Is by the CO2 equivalent. CO2 equivalent is the mass of CO2 that has the same GWP as the mass given of an agent in question. It enables the comparison of global warming potential of various gases. And it is global warming potential, it is measured over a century. So in simplified language, I'll be comparing the global warming potential of our anesthetic gases. So we measure their global warming potential in terms of with reference to CO2. So 1 hour of surgery using desflurane is equivalent to driving 200 to 400 kilometers of car, which will produce the same amount of carbon dioxide to the atmosphere. So this is the simplified version. Likewise, we have other gases also, like isoflurane, that will be equivalent to driving 8.7 miles per hour for the same amount of 1 hour of surgery with isoflurane at Mach will produce CO2 as emitted by the driving for 8.7. Likewise, sevoflurane for 4 kilometers, desflurane for 200 to 400, as we discussed earlier, nitrous oxide to 59 years. So this is the table showing the global warming potential and its related equivalents, like for how long these gases once emitted, for how long they stay in the environment and cause their global warming potential. Isoflurane, it has a lifetime of 3.2 years in environment. Sevoflurane stays for 1 year, desflurane for 14, and nitrous oxide, it stays for very long, 114 years, more than a century. And their 100-year global warming potential is shown in this table. And this is the CO2 equivalent of agent in its container in kilograms. I mean, in every container of the gas, how much CO2 equivalents are there. So this is the simplified version of environmental hazards of these gases. The same, likewise, sevoflurane, as we discussed, for the 6.5 kilometers, driving 14 kilometers for iso and nitrous, and this desflurane. So what, as an anesthesiologist, we need to transform in our practice? We need to avoid nitrous oxide wherever possible. Rather, we use oxygen air as the carrier gas and increase the volatile agents, because nitrous, that stays for the longest duration and has a very high global warming potential. Next, avoid use of desflurane except for rare occasion when it is really necessary. Using the low flow anesthesia, maximum 1.5 liter during maintenance in all the cases. And we need to monitor the depth of anesthesia to avoid the unnecessary use of inhalationals. And best is consider swapping volatile based anesthesia with the TIVA technique, total IV anesthesia technique. and use of regional anesthesia wherever possible. How to minimize the environmental impact? Reducing the usage of volatile anesthetics. Fresh gas flow, like we discussed, it should be, if using desflurane, it should be like 500 ml per minute, fresh gas flow. For isoflurane, less than 1 liter. And for sevoflurane, if used for more than 2 hours at max, it should be like 1 liter per minute because of the risk of compound A-induced kidney injury. And we should scavenging system in the operation theater, it should be working. Use of regional and IV techniques. Scavenging system is the most underrated, is given least importance in our practice, I think. Like I'm showing the picture from my OT. Here is the anesthesia gas scavenging system, but we just put one tubing from here to the outside environment. Rather, it should be like proper scavenging system should be there. Anesthesia gases should be collected from here, then their primary treatment, and then they should be sent back to the scavenging system. These are few trends in, these are few research articles showing the importance of environmental sustainability due to anesthetic gases. This is the 2024 article, published in 2024 article, showing the trends in volatile anesthetic SIVO and desflurane usage and its impact on carbon emissions. This is the desflurane decommissioning more than meets the eye. This is also the recent topic in which the NHS England will finalize the decommissioning of volatile anesthetic agent desflurane because it has a very high global warming potential. So how to go green in the operation theater then? These are the 6 R's of going green. Let's look into these R's. Rethink. Whatever you do, think of any green alternative. Next is the refuse. Next R is the refuse. Refuse means minimalistic approach. Before surgery, avoid unnecessary preoperative investigation. I mean, we need to navigate the things from the starting to the end of the surgery, or I mean, whatever CO2 we are producing, we need to fix that to reach a net zero carbon footprint. So we will start from right from the beginning. Preoperative investigation, they also should be avoided unnecessarily. Next is the reducing the amount of waste generated in the operation theater. For example, use of plastic syringes can be effectively reduced by drawing up the drugs only when needed. Next R is the reuse. Reusable equipment should be used whenever feasible, like Macintosh blade for laryngoscopy instead of plastic disposable blades. And washables, theater only hats, caps and shoe covers, they can be used again and again rather than disposable hat and plastic shoe covers. Recycle. It is essential to have the effective waste management, and we should constantly look out for the recycling opportunities. Potential recyclables are paper, plastic, and glass that should be collected separately. Next is the research. There is currently ongoing research on the topic of green anesthesia, and there are many papers and research going on this topic right now. I have discussed few of them earlier, aiming to lessen the life cycle environmental impact of equipment and drugs that we use. Because operation theater is very high resource using and waste generating place in the healthcare. So we as the anesthesiologist, we are producing the waste and these greenhouse gases. So it is our responsibility and to spread our awareness about these things to go green. So these are the 6 R's we can do to go green in the operation theater. And what else we can do beyond daily anesthesia practice? is the green meetings like we are doing now, virtual online meeting rather than going meeting in person. This can save energy, electricity, and use of public transport instead of driving private cars.
Last 1 minute, please.
Yes, sir. Achieving carbon neutrality. Carbon neutrality is a state of balance between carbon emission and its removal so that there is net zero carbon emission. National Health Service has set the target of achieving net zero carbon footprint by the year 2040. Tree planting is a meaningful activity for this carbon neutrality, and advocate and raise awareness like we are doing right now, giving talks on the topics to fellow anesthetists and trainees to is just as vital to achieving a more sustainable planet. This is the recent publication delivering a net zero NHS, as I discussed in my previous slide. So thank you.
डॉक्टर प्रीति, आपने बहुत अच्छा टॉपिक चुना है
थैंक
कि
यू सर।
ग्रीन, लेकिन मैं आपकी नाराजगी को से मैं बड़ा परेशान था कि जब आपने कहा ये दुनिया एकदम रहने लायक नहीं बची है, तो रहना तो हमको यहीं पड़ेगा डेफिनेटली,
Yes, sir.
बट वी हैव टू थिंक, इसमें कोई शक नहीं है। लेकिन क्या आप टोटली ग्रीन प्रैक्टिस करती हैं खुद, या आप खाली रिव्यू प्रेजेंट कर रही हैं यहाँ पे?
Sir, actually we all need to know and practice the TIVA and these regional anesthesia. I mean, if we will know, then only we will implement it.
मतलब मैंने आपका पूरा टोटली ग्रीन, योर हॉस्पिटल इज टोटल ग्रीन हॉस्पिटल, आप कर सकते हैं। आप तो ऑप्थेल्मिक सेंटर पे है,
Yes,
मैक्सिमम काम कटरेक्ट तो भाई एंटीरियर चेम्बर सब टॉपिकल में हो जाएगा एंड मिनिमल इंटरवेंशन नीडेड। बट हाँ, डेफिनेटली अदर सेंटर्स को अभी समझना पड़ेगा कि जो आप कह रही हैं तो वो कितना कहाँ इम्प्लीमेंट कर सकते हैं, क्योंकि टोटली बाकी लोग तो शायद उसको प्रैक्टिस करना पॉसिबल नहीं है प्रैक्टिकली इंडियन
Yes, sir,
सेटअप।
but wherever possible, we should do we should use the recyclable, I mean, reuse the caps and masks, caps and shoe covers like this. Because everything nowadays, we use everything new for the patient, disposable ones at that level.
Okay, madam.
And sir, use of total IV anesthesia, as there is conference also going on, World Congress of SIVA. 1 week later, just 1 week later. So we need to learn from there also about TIVA and considering into the practice.
Okay, thank you.
Thank you, sir.
Okay, Dr. Dhir, suppose if we give you the responsibility to make a guidelines or SOP for your institute to implement this green anesthesia concept. So what will be the salient points which you want to apply in your hospital for all the anesthesiologists or the departments working there?
Yes, sir. Sir, as we discussed, 6 hours, they are the, I mean, main green, for the green OR, we need to work on these 6 hours. And we need to avoid, sir, like in my practice during ophthalmic surgeries, or I mean at my center at least, where we have the surgeries for short duration that can be done under total IV anesthesia also. And sir, waste management, that is also a very vast topic and very important topic for the recycling of the things.
Suppose I give you an option
Yes,
to imagine something better.
okay.
It is totally an imagination. What do you think? If you have a power to control this greenhouse effect, what you will do on your own basis?
Sir, I will consider for total IV anesthesia.
Okay, perfect. Thank you.
Thank you, sir.
Thank you. Shall we go ahead, sir?
Yeah, please. Next one.
Okay. Dr. Yogita Agarwal, are you ready with your slides?
Yeah, I'm sharing her slides. I'm sharing on her behalf. Okay, yeah.
Okay. Good evening, everyone. I'm Dr. Yogita Agrawal. I will be speaking about dilemma of anesthesiologist in a patients coming with ASD with pulmonary hypertension for LSAS. So now the question is, what is ASD? So ASD is nothing but a congenital heart defect which is abnormal opening in the intra-arterial septum. It is the most common type of cyanotic congenital heart disease, compromising upon 6 to 10% of all the congenital heart disease, and it's more common in females with a ratio of 2:1 as compared to males. And depending upon the part of the septum which has not developed properly, it divided as ostium secundum, primum, sinus venosum, and unroofed coronary sinus, of which ostium secundum is the most common. Next. So why we are discussing about it now? As we know, in a non-pregnant females or in a normal adult, ASD remains asymptomatic for whole adulthood, and is generally symptomatic in a very after 40 years of age. But in pregnancy, due to the additional strain caused due to the physiological changes, there are increased chances of instability and complications, which can lead to increased mortality and morbidity. In if addition to it, if portal hypertension is present, the mortality increases to 3 to 43%. And if Eisenmenger syndrome or reversal of shunt present, then increases to 50%. That's why WHO has classified this as a class 4 indication and has advised against the pregnancy, and if pregnancy is present, has advised to terminate it. Now, this is the case series of 6 patients in which we have 6 patients who had ASD and came for LSCS with different indication, and we had given tailored anesthesia according to that. Let's discuss one by one. So case 1 is ASD secondum with left to right shunt, G2P1 at 36 weeks gestation, dilated RARV, left to right shunt, severe TR, mean arterial pressure of 35 to 40 mm of Hg, came for fetal distress. That's why we had given general anesthesia. Procedure was uneventful. Case 2, same ASD secondum with left to right shunt, G2P1 at 34 weeks of gestation, dilated RARV, left to right shunt, 40 to 45 mm of Hg mean arterial pressure, and came for elective LSAS. So we had given a epidural anesthesia, and procedure was uneventful. Case 3 is again ASD secondum with left to right shunt. It is wrongly right to left written. G2P1 at 35 weeks of gestation, dilated RARV, and then 40 to 45 mmHg of mean arterial pressure. Again, elective LSCS came. So we had given epidural anesthesia. Now case 4, again ASD secondum with left to right shunt, primary 37 weeks of gestation, dilated RARV, left to right shunt, again with fetal distress, so given general anesthesia. Can you place one more time, please? So this is case 5, which is a very interesting case because this was a ASD secondum with bidirectional shunt, which was primary 28 weeks of gestation, class 4 indication by WHO. So and pulmonary artery pressure of 120 mm of Hg. So MTP was decided, and till the legal procedures were going on, patient was kept in a safe confinement, and after the legal procedure, MTP was done. Procedure was uneventful. Then case 6, it was a repaired ASD, normal 2D echo findings. So spinal anesthesia was given again for elective LSCS. Now let's understand it. Among the 6 patients, 4 had a 4 to 6 mm of ASD defect with mild to moderate pH, which according to the indication we had either given GA or epidural. Then one case which was large ASD with very high severe pH on double vasodilators, MTP was done, and the last one was the repaired ASD. So every case has a very meticulously was planned between the anesthesiologist, cardiologist, ops people, and neonatologist. That's why every patient required a very personalized anesthesia plan, comprehensive evaluation, optimization, and a very multidisciplinary approach. So now we will understand what are the pregnancy implications on a patient with ASD. As we all know, in a normal pregnancy, there is an increase in cardiac output, blood volume, decrease in SVR and PVR to accommodate all the increased blood volume by vasodilation. But during ASD with pulmonary hypertension, there is a rigid pulmonary vasculature which cannot accommodate such a big volume increase. That's why there is a load on RV, and there can be RV overload, RV dysfunction, and other complications related to ASD. And if we combine all these again with during the labor, one more time, please. Then the pain reaction during the labor, the massive volume shifts, the stress response, the hypovolemia, blood loss will again make the situation very worsen and can also lead to peripartum maternal death. That's why That's why we need to decide everything. That's why we need a multidisciplinary approach. Now, deciding upon the mode of delivery, in our institute, we prefer C-section. Why? Because it avoids the Valsalva maneuver during the vaginal delivery. It decreases the physiological effects of the labor, which include pain reaction, catecholamine release, and it helps us to shorten the second stage of labor. So, by well coordinated if communication between the anesthesiologist and obs, we have in our institute always given LACS. We have always performed LACS. Now, next is the anesthesia plan. So, what should be the anesthesia plan? Now, all it depends upon the condition of the patient. Is it hemodynamically stable, not stable? Are there any complication related to anesthesia, ASD, and the indication of the LACS? So, as we seen, since case 6 was very normal to do echo, and elective LACS we have given spinal. For 2 patients which we had fetal distress, though were stable hemodynamically, we had to give GA. But all other cases, it is epidural is the choice of anesthesia. Why? I would be explaining. So why epidural? So as we see in spinal anesthesia, there are rapid hemodynamic changes which we cannot afford in ASD patient. And during GA, due to the effects of the drug, there will be a cardiac depression and increased sympathetic activity during laryngoscopy, decreased preload, increased PVR, effects of the difficult airway during the pregnancy, decreased FRC, risk of hypoxia. We generally avoid GA. With epidural, we have the advantage of graded doses adjustment, hemodynamic stability, and most important, which is post-op analgesia. And but the disadvantage of epidural is it is time consuming and the catheter placement is risky. But if we have a chance and a patient is coming electively and has everything on a go, is everything optimized, then we should be going with epidural. And there are enough study about it, and there are enough data available that shows that epidural is a anesthesia of choice for this. And not even combined spinal epidural, plain epidural has been always been a choice of anesthesia. Now, what should be our anesthesia goal? So what we have to do in this cases is we have to whatever the shunt is there, we just have to keep it like that way, neither to increase the left to right shunt, neither to increase to right to left shunt. So what we try to do is what we our goals are to keep normotension, normothermia, normoglycemia, and avoid shivering, acidosis, hypocapnia, hypercapnia. In short, we have to avoid increase or decrease in SVR, or avoid increase or decrease in PVR. So for these cases, we generally do go for epidural because it will avoid the sympathetic stimulation with laryngoscopy. It will avoid the effects of the anesthetic drugs, and we can have the graded response which is possible, which can be avoided by the spinal anesthesia. So what I conclude with this, so early registration and risk assessment of this patient. So since it's a multidisciplinary approach before coming to the anesthesia, ops people has to be very keen about an assessment and whole workup, and they should always advise this patient to go to the tertiary care center and for a regular follow-up. And if indication is there, then avoid the pregnancy or discourage for the pregnancy. And then again, for us anesthesia people to communicate clearly with obstetrician and discuss the anesthesia plan and discuss the indications and contract indication. And with obviously we have to make sure that there's a post-operative ICU availability and a neonatologist availability. And the goals, as we were discussing, that we have to maintain PVR, SVR, heart rate, MAP, oxygenation, ventilation, and avoid obviously acidosis and shivering. Thank you so much.
Thank you, Dr. Yogita, for nicely managing your all the 4 cases safely and your experience in managing ASD cases.
Yes, sir. Thank you, sir. Actually, these were 6 cases, and one was normal repaired ASD, and one was very high risk associated ASD with pulmonary hypertension, which pregnancy has to be terminated. But it was a sir very good series of the patient, and we had been able to do all the cases very successfully and manage them in our own ICU post-op better way, sir. And all patients were discharged after 3 days from the ICU to the ward.
So if this patient has come during second trimester, okay, and corrected ASD come to you in second trimester, then what is your advice? This patient first to be have the cardiac surgery to close the ASD, or you will advise to continue pregnancy like this and you will take all challenges later on?
So in our institute, we have those patients also where we get the patient for ASD closures also in the second trimester. So we have those patients also. So I had done those cases. So we had advised to for the ASD closure. If obviously all the indication, all contraindicate, if there is no other contraindication for the surgery.
Do you also have experience of simultaneously means doing at term that the of OBG is doing cesarean delivery and the cardiac surgeon is doing on same table together the cardiac surgery correction of the
No,
ASD?
sir, no, sir. No, sir, I haven't.
Okay, thank you.
Dr. Yogita, so as you have managed all the 5 cases basically very well, and the sixth one is very well managed, although almost the ASD closure has been done. So, as per overall picture, overall management of the cases, which is the most common parameters, hemodynamic parameters need to be considered before going for anesthesia to such patients? Whether it is the which particular parameter you would like to say that we need to keep it in mind on a priority basis.
Sir,
Have you got my question?
no, sir, sorry.
No. Oh, okay, fine. Suppose if we just consider the cardiovascular system before heart, and after heart. So AST is a condition, and there is so much of fluid shift during regional blocks, sort of a fluid shifts. Because of sympathetic blockade, and there is an almost altered physiology and pregnancy. So in such in such situation, if I ask you to advise your postgraduate residents, just keep these 2 or 3 parameters in your mind before selecting your anesthesia, opting for your choice, any type of anesthesia.
So for this patient, hypotension has to be really avoided because it can decrease the SVR. So for this patient, we need to see hydration has been occurred meticulously before giving anesthesia. Basically, we need hemodynamic stability. And the other things are the pulmonary hypertensions, because this patient, if we give general anesthesia or any anesthesia, there is a sudden increase in PVR. So this patient can have reversal of the shunt. So we have to avoid increase in PVR also. So basically decrease in SVR by hypotension and blood loss, and increase in PVR by too much of PPV or acidosis or shivering. So we should be avoiding those 2 to 3 parameters.
Okay, thank you.
Shall we go ahead, sir?
Yes, we can go ahead.
Our next speaker is Dr. Praveena. She is assistant professor and in charge critical care in Geetham Hospital, Andhra Pradesh. Her topic is Focus Blue Protocol. Dr. Praveena, you're there?
Am I visible? Like my screen is visible?
Yes, you're visible. You can start.
Okay. Good evening, everyone. I'm Dr. Praveena. I would be very grateful to discuss on this platform. Now I'm going to discuss the utility of point of care ultrasound, lung ultrasound, especially the Blue protocol. So why do you need to discuss regarding ultrasound? As we all know that ultrasound and the skill of using ultrasound is being getting moved away from the radiology, as anesthesiologist and even emergency medicine physician, everybody is using ultrasound in the recent times. So what is the great thing about ultrasound, and why we should use? It is a real time. We can see that we can see what is happening to the patient instead of waiting for the X-ray or CT to be done. We can manage the patient. We can take a clinical decision, and even if for example, if we are doing a thoracocentesis to the patient, after seeing ultrasound, and you can see how the lung is really after thoracentesis is done. So we are going to see the trend. We can analyze the trend and we can go ahead along with the decision making. So portable bedside ultrasonography is being increasingly used by the clinicians in the patient who are critically ill, and the critical care ultrasonography is the most commonly used in emergency and in ICUs. It can be used even in the operating room, post-operative care unit when evaluating patients who become acutely ill in the hospital. So image acquisition and interpretation are performed by the intensivist at the bedside, and the imaging results can be immediately interpretable and integrated into a comprehensive management plan. It is best suited for the patient with imminently life-threatening process to categorize the shock and respiratory failure. It is a complementary diagnostic tool to the standard pathways, and even it has great sensitivity and specificity. So point of care ultrasonography has been shown to be a value in the evaluation of acute dyspnea in the emergency department or the intensive care unit. So how do we have different protocols, but I would like to discuss blue protocol here. Blue, which means a bedside lung ultrasound in emergency. It is an algorithmic approach to evaluate the acute respiratory failure. Here, the examination of the three well-defined points on the thorax, mainly the anterior, lateral, and posterolateral bilaterally. Based on the findings, we can go to the etiology of the respiratory failure, and it can be identified and it is managed. So as we all know, the physics of the principles of ultrasound, it is based on the piezoelectric crystal activity, and based on that, we have the three different categories, whether it is hyperechoic, which can be seen in the pleura or bone, and anechoic, it can be fluid or blood, which is black in color. Based on that, we will be able to analyze the lung condition. So this is the area, this is the picture depicting the performance of how to put the probes, either longitudinal or transverse probes. In blue protocol, it is developed by the Lichtenstein. It is a protocol for diagnosing respiratory failure. Supposing if a patient enters to your operating room or an ICU with a respiratory failure, how do you evaluate the patient in an early way? So where do you scan? So we have 3 points, mainly the upper blue point, lower blue point, and flaps point. Imagine a patient lying in the supine position, keeping the hands on a stretch parallel to the clavicle. So your upper blue point will be the same ring at the middle point of the ring and the middle finger, and the lower blue point will be the middle of the palm. And the line drawing joint perpendicular to that will be the flaps point, which is a posterior and lateral alveolar pleural syndrome. So this is the blue protocol algorithm, though it is seeming to be hectic, which is actually easy if we learn to know. First, we have to see the lung sliding, which I will be depicting in the coming slides. So first one, we have to see the lung sliding, whether it is present or not. If a patient is coming with a shortness of breath, and if you put your probe, we will use a linear probe for seeing lung sliding, even though we can use curvilinear probe too. Linear probe, which is a high frequency probe, if we see the lung sliding, which I will be showing you, it will rule out the pneumothorax. So these are the small wormy kind of movements this is the white line glistening structure which is the pleura, which is hyperechoic, which is parallel to the skin, and the wormy movements which we see here are because of the lung sliding. If the lung sliding is present, we are happy. There is no problem like pneumothorax. If there is a lung, if we turn on the M mode, we can see this picture. We can see this like seashore, where we call seashore sign on the lung on M mode. Suppose if the lung sliding is absent. Am I audible?
Yes, you are audible. Please carry on.
So suppose if the lung lining is absent, then definitely there is a problem with the lung. Then you have to rule out the possible diagnosis, which could be a possible pneumothorax. Even though absence of lung sliding doesn't mean there is a pneumothorax, there are other conditions too. But the presence of lung sliding will rule out the pneumothorax. It will actually rule out rather than rule in. Now coming to the patient. So what is the actual, how do the actual normal lung look like? So this is the pleural line, which is a glistening structure, hyperechoic glistening structure parallel to the skin, and these are the A lines. A lines are the parallel reverberating artifacts. These are the reverberating artifacts which are in depth, which are parallel to the A lines and at exactly equal depth to from the skin to the pleural line. These are like infinite. They will keep on going. This is the normal structure of the lung. So you can see the A lines, pleural line, and parallel to that are the A lines. So coming to the next thing is B lines. What do you mean by B lines? B lines are like, as I said earlier, A lines are the normal phenomena where we can see the reverberating artifacts. These are the B lines are the vertical artifacts. That means uh, that arising from the pleura, there will be pockets of like rather than calling like torches of light, kind flashes of light. These are described as torches of light or flashes of light, which will be starting from from the pleural line and will be extending vertically into the infinite depth. These are the B lines. Generally, if it is more than three, it will depict like if you put on the steth, you may listen to the crackles or crepitations. So it will, if you see a patient with the B lines present, then probably you are dealing with the pulmonary edema. So this is a shred sign where you can see, as I showed you, normal pleura. Here you can see this is the pleural effusion, and a fluid will be like black in color. This is the diaphragm, and the down will be the liver. Here there is a lung collapse, where you can also see there is a shredding of uh, shredding of pleura. That means pleura will not be very nice. It will be like broken down because of this, it is suggesting subpleural consolidation. Now going back to the blue protocol, supposing if a patient has come to your AD or ICU with a respiratory failure, first of all first you do lung sliding. If the lung sliding is absent, and then go ahead with either it is A profile or B profile. Suppose if the lung sliding is present, and if you see B lines like the like rockets, if they are coming, you probably you are dealing with pulmonary edema. If there is no fluid, there is no evidence of B lines, and there is only A lines, if you can see, then you have to go for the further next step. And if you see any pleural thickening or subpleural consolidation, probably you are dealing with pneumonia. Suppose if the patient is having A profile, there is no fluid in the lung and there is no consolidation either, then the next step will be we have to check for the thrombosed veins. You will be checking for the thrombosis of the veins at the femoral, popliteal, saphenofemoral junction. If there is a thrombosed vein, then probably you are dealing with a pulmonary embolism. If there are free veins and veins are collapsible, and how much do you collapse? How much do you compress? Compressibility, you see, as long till the time artery is getting compressed, you have to see. If your artery is getting compressed and vein is not getting compressed, probably you are dealing with a thrombosis, and maybe it is a thromboembolism. So if there is the veins are normal and there is no B lines and you are dealing with A profile, you have to check whether it is a pneumonia. If there is no C lines too, consolidation or pleural effusion, probably you are dealing with a COPD or asthma. In the rather than first scenario, if there is no lung sliding is absent, then first you have to rule out the pneumothorax, and probably you are dealing with a life-threatening emergency, and you have to go to the next point, like where you have to see the lung point. Lung point is a thing where you can see the normal lung movement of the normal lung, and there is no movement with the abnormal lung is collapsed. I'll show you. So this is the lung sliding. If the lung sliding is absent, there is no wormy movements at the pleura, and pleura in below which you will be, it is like absent. And if you put an M mode on the at this point, at this time point in this line, you can see the barcode sign where we get a seashore instead of seashore sign. We'll get seashore sign because of the movement of the sorry, movement of the air below the pleura, but because there is no movement and it is absolutely there is no movement, just like the skin and subcutaneous tissue above the pleura, we are not going to see any kind of movement, which depicts like barcode sign. And this is the pleural effusion. As I said earlier, it is like anechoic, fluid will be anechoic, and different kinds of pleural effusion also it can be noticed. And here this one is showing the where it is moving. It is a jellyfish. It is called jellyfish sign, where collapsed lung is moving in the fluid. There are other signs also, sinusoid sign, quad sign. And we can also see through the ultrasound, we can also see the type of effusion. If there are exudates, how it will appear is loculations, or if it is a gray color, we can check. So how do we detect DVT? It defines thrombosis as the non-compressibility of the imaged vein, and we use a high-frequency linear transducer for the assessment of DVT. Compressible veins are considered patent without thrombus, while non-compressible veins are diagnostic of thrombus. If a thrombus is visible within the vein, the compression component of the examination is required or may be rarely associated with the dislodgement of thrombus. So as I said, we generally commonly see at a femoral vein and femoral artery junction, saphenofemoral vein junction, popliteal veins. So what are the limitations of the ultrasound? It might be the patient-specific factors, such as patient might be obese, where you may not be able to see massive edema, heavy musculature, chest wall dressings, and inability of the position the patient and critically ill patient may provide limitations to us. That's all, sir. Thank you.
Over to the judges to ask the questions, please.
So, Dr. Praveena, you are working in ICU or in the OT?
Sir, I'm working in ICU.
Okay. And you are routinely doing this focus in your daily rounds, or?
Yes, sir. We are doing routinely.
Okay. So all the clips were yours.
Yes, sir. Majority of our clips, maybe one or two, I have to take it from internet.
So how many means in do really focus you are able to avoid the radiological investigation like CT and X-rays nowadays, or still we have to besides doing we have to do that in
Sir, we
sepsis
are
patients?
able to replace X-rays in our place, because we can see, and even we are able to convince the other departments by showing the ultrasound, because it is a real time. I'm doing ultrasound and I can show them by doing ultrasound. They are also on par with ultrasound. But obviously for confirmation, there is a CTs, as of now CT we are doing, sir. But it is not like a routine like earlier days. Maybe it is like daily X-ray for a patient in ICU. Maybe they used to ask daily X-ray, but that daily X-rays we have stopped using, sir. The moment we come patient with a respiratory distress, we are doing ultrasound. Obviously, everybody is convinced. We are able to eliminate X-ray, but not CT. For confirmation purpose, we are doing CT.
Okay, thank you.
Okay, Praveen.
Sir.
So what is the threshold of doing ultrasound in ICU admitted patients in your setup?
Sir, actually, ultrasound per se focus not only lung, we do for the multiple purpose. Like if a patient is admitted to the shock, we first thing, because of the dynamic parameters, we check IVC and then lung. For fluid management, we are using it. Actually, we are doing it on a routine basis. So we are training even the junior residents, and we have included as a part of the basic thing, which when the patient enters either with the shock or respiratory distress, we are doing it mandatory.
So how do you prevent cross-contamination or cross-infection among patients while using ultrasound?
Sir, as of now, that is a difficult task. We are using hand sanitizer. Even we are covering the probe with the glove because of the financial constraints. We can't use a probe cover to every patient. We are using a sterile glove cover so that it will prevent minimum infection.
So how do you maintain interface between your probe and patients if you cover it with gloves? Because there is a thin layer of air between that.
Sir, glove and patient, we'll use with either with saline or sanitizer, sir. Most
Now,
common saline.
most commonly saline.
Yes,
Okay.
sir.
So, what is your recommendation? Whom should practice this ultrasound in emergency or ICU? Which the all healthcare workers, that includes doctors as well as nursing staff as well as technician. So, which is the group of those healthcare worker which should be trained and which should use it frequently while handling such patients?
Sir, I suppose ultrasound, like in ICU setup, we use ultrasound, definitely not like a radiologist or a cardiologist, but we should be able to tell the moment the patient is in shock, we should be able to tell whether whether his heart condition is good, or like contraction is good, or some regional wall abnormality. To that, maybe intensivist stops there. We till the time we get a real cardiologist opinion, we can manage the patient by seeing the basic parameter, whether the heart is good or it is not contracting, or patient is really volume depleted, that is why bp is low. That much I think every intensivist should follow that.
So,
It-
should it be used by the intensivist or other specialty people also for diagnosing or intervening such patients?
uh, Other specialties, they can use it, sir, but we are commonly using, so we have more confidence on that. They are in the, I think, being general physicians, they were in the learning curve. It has many interpretation where we are using, even for raised ICP you are seeing, we are seeing optic nerve sheath diameter.
Okay, fine. Thank you.
Thank you, sir.
Thank you, Dr. Praveena. We'll move on to the next presenter for today. So we have with us Dr. Thenge Arsu. He's working as a consultant. So he's working as a consultant pediatric cardiac anesthetist at Sri Padmavati Children's Hospital, Tirupati, and he'll be talking on the advancement in the perioperative management of high-risk pediatric patients. Over to you, Dr. Thenge.
Thank you, sir. Good evening, respected dignitaries and fellow colleague anesthetists. Today, I'll be talking about advancement in perioperative management of high-risk cardiac patient, which is not pediatrics, adult, from a non-cardiac anesthetist perspective. Disclosure is I'm a cardiac anesthetist. The topic is a very old topic. Since my the residency period, this has been everybody would have been going through this guidelines and all sort of this. But why I took the topic, very old topic, is that still though guidelines are there, it is like I from that time I have a practical difficulties, and now also I get a lot of calls from juniors and fellow colleagues that how do we manage practically. So thought of it, give update on this and what are the pitfalls in this guidelines. So we'll go through this topic under this headings: risk stratification and pharmacological updates, how do we monitor, optimizing the fluid management, post-operative care, and emerging trends. So this is the guidelines I'm talking about, 2014 ACC/AHA guidelines for management of non-cardiac cardiac patient for non-cardiac surgery. So I'm pretty sure everybody will be aware of these guidelines. But my worries started from the residency period. That first point is when the patient is branded as emergency surgery, just go ahead. But what is emergency? For the surgeon, everything is emergency when it has come to the anesthetist. So we have to decide a patient on emergency, what is emergency, particularly when the patient having the cardiac disease. So the second point is clear cutly they said the patient is having acute coronary syndrome, treat according to the guidelines. If there is no ACS, proceed to step 2. And my question is, what only acute coronary syndrome? What about the decompensated heart failure, severe arrhythmia, and symptomatic valvular disease? They are equally problematic when it comes these diseases. And the third point is assess the MACE risk, which is major adverse cardiovascular events. The question is how to assess the MACE. That still there is no clear-cut guidelines as there. And the fourth important point, access the meds, go ahead if there is 4 meds. But the point is it subjective or objective? Patient can say problem with nowadays if you see a lot of disc problem, so those patients they will restrict by themselves, and we will fastly interpret their meds is high. But to be very frank, if they run it only, we will come to know what is their meds. So to go for objective things like CPET or indexes like a Duke Activity State Index. And the final step is go to the stress test. And if the stress test is abnormal, send for the cardiologist and evaluate further. So the first point is risk assessment. Why we do to optimize the perioperative care. So subjective or objective is the question. So this is what I'm talking about, the very old Lee's revised cardiac risk index. If you see the index here, everything is a single parameter. Like any ischemic heart disease, give a 0.1. Congestive cardiac, give a 0.1. So finally, we'll come to the cardiac risk score. I'm sure everybody would have been send it to the cardiologist, and finally they'll say low risk patient can be taken under low risk. What does mean to us? It does really nothing. And the second elaborative thing is the ACS NSQIP, which is this scoring system is a very comprehensive, but it is practically difficult to go through all the parameters. And finally, they will give same high, intermediate, low surgery or low risk, and any emergency is considered as high risk only. So to validate the both this one Gupta perioperative cardiac index, this is just relatively outperformed our league revised cardiac index. So here, till these three parameters, we don't include any markers. So this is the algorithm from the Swiss. They included when the METS is less than 4, including the markers of BNP and NT-proBNP, and troponin both before and after surgery. This is just a proposed algorithm. It does not come as a guidelines. So these are the pitfalls which is there in the first thing. It's a risk stratification itself. So we'll give you a little bit of solution for this at the end of the talk. So when it comes to the therapy, so most of the people will have doubts about which drug to continue, which drug. It is clearly guidelines are there, but how it is misinterpreted is, for example, two things in beta blocker. When we say NPO, most of the even cardiac patients happen. The patient they'll keep it. Sisters will be keeping absolute NPO, but they don't even give a beta blocker. That is completely contraindicated. We should give beta blocker. It doesn't matter. Just sip of water. We have to give a beta blocker. And certain physician or from a other side, surgeon side, they will be knowing some little bit about this ACCHA guidelines, and they'll start beta blocker just before one day. It is that again, it is completely contraindicated. We should not encourage that, or we should not take. If they've given a beta blocker, postpone the surgery for 1 week, see the response, and then we have to take it. The second thing is statins. Yes, it has to be continued. And initiation of statins in a vascular surgery from your side itself reasonable is a class 2 indication. When it comes to alpha 2 agonist, as per guidelines, there's no recommendation, but we use dexmet in and out. I'm sure everybody is using, and it has shown that it has reduced so many events and included the rise in the prevention of rise in the cardiac markers and stability. So I'm sure later this guidelines may change. And regarding AC inhibitors, very important this guidelines say it's a class 2 indication to continue of AC inhibitors or ARBs reasonable, but practically what we do in non-cardiac surgery or cardiac surgery, it is better to avoid. We don't because they may go for vasoplegia, and if you go to hypotension until it is very difficult to treat. So the important point in drugs is the patient who coming for a cardiac surgery is a stented patient. I'm sure out of 2 out of 10 patients will become, most of the patients are stented. So when they come, what is to be done? It is still revolving around the question. So when you have to see the hemorrhagic risk when they come stented patient, and when I say stented nowadays, most of the time it's a DES, drug-eluting stents. Barometer stents are almost absolute. So when there is we see the hemorrhagic risk. If the hemorrhagic risk is, thrombotic risk first. So when the thrombotic risk low means what? If the drug-eluting stent happened 1 year back. So 1 year crossed, again, just go assess the risk for hemorrhage. If it is low, just continue the DAPT, dual antiplatelet drugs. And if it is intermediate, just maintain the aspirin, discontinue the clopidogrel. And if it is high risk, discontinue both, because the thrombotic risk is low. When it comes high and intermediate, what do you mean by high? If the drug-eluting stent less than 6 months before, or intermediate, which is 6 months to 12 months, the gap. So try to delay the surgery. If not happen, then somehow you have to do the case. It's a time-sensitive surgery. Then again assess the hemorrhagic risk. In both case, if it is low hemorrhagic risk, continue DAPT. Okay, and if it is intermediate, again continue aspirin at any cost. Consider bridging in case of high risk. Otherwise, just maintain aspirin in case of low intermediate risk. In high risk cases, obviously we have to discontinue, but again consider the bridging with heparin. So how do we assess hemorrhagic risk? There is a list of surgeries are there. I just put it here later. And so when it comes to the interruption, how long we should interrupt? That's the question. So when it comes to aspirin, it is just 5 to 7 days is old. Nowadays, 5 also is acceptable. Clopidogrel again, ticagrelor, both are 5 days. Prasugrel 7 days. So again, when we come, the practical difficulties with the clopidogrel is even 3 days patient won't bleed, even 5 days patient might be bleeding because of we know that P2Y12 receptor of very genetic polymorphism will be there. So we can't predict as such until unless you do a platelet reactivity testing. So it is again quite complex. So when it comes to intravenous, nowadays people started using it, terofeban and tifibatide for 4 to around roughly 8 hours. Cangrelor, which is a short acting 60 to 1 to 1.5 hours, you can stop it. And when it comes to intraoperative care and monitoring, people generally try to avoid sometimes volatile anesthetics. They say it's a cardiac depression, but there is no guidelines that say that TIVA or volatile anesthetic, both are reasonable class 2 indication. And when it comes to neuraxial pain management, absolutely indicated. Comes to the neuraxial, this is the old guidelines. So people are talking about neuraxial. Nowadays, the superficial blocks are outperformed all the things. So neuraxial anesthesia is a class 2 indication. And the myth is that people start using intravenous NTG, which is not effective in reducing myocardial ischemia. So for non-cardiac surgery. So it is clearly class 3, no benefit. And again, same thing people sometimes use is the intraoperative TE for routine non-cardiac surgery and pulmonary aortic catheter, which is not recommended. So where it is recommended, when it is highly complex patient and the most problem is both the technique is we should know how to interpret. It is not just using it, it is how to interpret it's a matter. And same thing for the hemodynamic assist devices also. So cardiac grid, this is the most important slide in this, I feel. So when it comes anything patient coming for non-cardiac surgery, fix the goal. You want to write it and keep it with you, and then work towards that. Like the cardiac grid comprises of preload, afterload, heart rate, contractility, and PVR. Which is, sorry, I missed it here. So when it comes to the stenotic lesion, either aortic or mitral stenosis, preload should be on a higher side, afterload should not be reduced. PVR should be normal, contractile should be maintained, heart rate should be on the lower side. And when it comes to and one exception is that in a dynamic obstruction like hypertrophic cardiomyopathy happens, then the contractile should be down, like you have to give a beta blockers for that. So when it comes to the regurgitation lesion, preload should be already will be low volume load, so you have to be keep optimized, and SVR should be opposite of stenosis. SVR to be down, PVR should be maintained, heart rate should be on higher side, contractile should be maintained. So every case, work on this cardiac grid and make a goal, then work for it. So the other thing is new concept of this rescue TE. What is rescue TE? It's an unplanned TE examination performed on an urgent basis to diagnose important hemodynamic instabilities, both used in non-cardiac surgeries and cardiac surgery in even state. And AAC recommends that even in a cardiopulmonary arrest situation, and for the guidance of diagnosis or prognosis or procedural guidance in case of cath labs procedures. So events to exclude is that hypovolemic shock and cardiogenic shock, tamponade, pulmonary embolism, hypertrophic cardiomyopathy where the LVOT was happening, aortic dissection, and is there is any ASD or PFO shunting in case of embolism. So these are the things to be excluded when you do a rescue TE. So these are the certain what do you say, this views when people who knows TE a little bit less. This is a mid-esophageal 4-chamber view, and this is a long axis view where here we can see the valves and MR and TR, all this, and even a focused view we will see the pattern foramen well. Here LVOTO we can be assessed. This is the transgastric mid-papillary short axis view where we'll find out the RWMA and hypovolemia. And here is aortic views, both are upper esophageal views, both for diagnosis of aortic dissection. So this is on paper say that the difference in hemodynamic variables and ROSC when the chest compression over the LV were compared to compression over the aortic rate. That means they're saying when you do a chest compression, we don't know really where we are doing. If we are hydrogenically compressed the LVOT. So that can be detected by the rescue TE, not definitely TE. We cannot TTE, we cannot even do that. So that in that case, TE is helpful. And when it comes to the fluid management, that's again $1 million question. So like hypovolemia and normovolemia, everybody knows, nothing to be more worried about it. But hypervolemia also equally deteriorates, so we'll be very cautious about fluid. How do we manage fluid? Again, so that is where the term uses called the GDT, goal-directed therapy. So use all the thing. It is not about the only preload. It is a tissue oxygenation, DO2 index. So use use the parameters to contribute the tissue oxygenation, which is preload, contractility, and afterload. So when it is required, we should give. So how do we decide the preload is optimum or not? So we can go for a invasive devices from invasive, fully invasive to the non-invasive devices. We know PAC is a standard of care, intermittent and continuous, but not in a routine cases or only in a complex cases. And person should know how to interpret this. And the minimally invasive, I'm sure most of the people nowadays using it, LitGo, PICO, FlowTrack, and TE, as I said. Non-invasive was coming up with particularly this thoracic bioimpedance and bioreactance devices. Apart from this, and there's one more device called it's like the same like our SpO2 sensors, this photoelectric plethysmography, next thing and one thing. So this is a simple example. How do we do a fluid challenge? Suppose if you want to give a fluid challenge, what we generally traditional teaching is that look at the parameters of heart rate and BP. No, never. So we can give a bolus, whatever the bolus, and preferably of a crystallite solution rather than a colloid. Now, based on a revised Starling hypothesis, look for the stroke volume increase of 10%. If it is increasing, then the patient is the fluid responder and responder and go ahead. Otherwise, stop and think what can be done. Look for the conductivity, and afterward, that's what other parameters to be optimized to get the perfusion index, like DO2 index.
Dr. Thangai, last 1 minute left.
Okay, thank you. And when it comes to the perioperative care, like post-operative care, it is just continuation of care. It's not that, okay, what I have done, then patient has been shifted. So continuation of care with appropriate hemodynamic monitoring, restart the medication depending upon the clinical circumstances. And when it comes to the troponin levels, any signs of ischemia, myocardial ischemia, please do a troponin and ECG. Routine screening with troponin is not indicated. This is the first international web-based conference. They said these are the things which is improving the perioperative mortality rate in non-cardiac surgery. Here we look, clonidine is given here. So that's why I said guidelines may take time to develop. So this is and very important is perioperative MI. Most of the time we deal with the type 2 MI. So any elevated cardiac troponin, stable levels, don't worry, it is a chronic myocardial injury. If there is any rise and fall, like trends, you have to see. If you branded as a PMI, look for the ischemic feature. If no, look for the other causes of acute myocardial injury. And if it is ischemic features are present, if it is embolic, like if most of the time what we see is type 2 myocardial MI, which can be treated with the supply and demand mismatch. And the emerging trends, patient definitely now in the future we will going to see the patients with the because of the technological advancement and mechanical circulatory devices, so many mechanical circulatory patients like VAD patient will coming to you, newer drugs like Arnis, Vimeda, directly acting anticoagulants, and biomarkers like usage of biomarkers, technology like patient with a TAVI, patient with transpulmonary catheters, congenital adult cardiac patient, and uses the handheld echo preps. Already last presenters already beautifully explained about the focus and blue protocol, and there is other protocols so also there, and definitely application of AI in the predictive algorithm, as first slide was discussed. Better predictive algorithm can be developed. So go back to the first slide. So the point is, we can even it is emergency surgery, consider the echocardiography by yourself. And again, when the MET is less than 4 or unknown, consider the Swiss algorithm, which is BNP and troponin. And if there is stress testing is not able to done because of the patient implicated factors, go for a CT coronary angiogram, which is equally effective. So these are the included parameters. It's just suggestion. So the take-home message is that previously the cardiologists used to give the risk parameters. I'm sure they have absolutely no idea what's happening into the war. At what point of time the patient is going to be stressed, whether it is an induction or extubation time, and what drugs we use, and what are the parameters to be taken care. They just give low risk or intermediate risk. Even I have not seen they would have given high risk also. So it is a time to change to the anesthetist itself, that we are in a better position to decide which patient to be high risk, which patient to be taken care, what has to be taken care in the perioperative care. So because we are a perioperative physician. So thank you for patient listening.
Over to the judges.
Dr. Thanigai, I really appreciate I really appreciate your vast experience in cardiac anesthesia, and you have incorporated your clinical experience with the protocol.
Thank you.
So what is about the factor X means when your hospital director is a cardiac surgeon and he say, dear, I have to do this case. And you know that sometimes these cases, as per our knowledge and science, it says that the case is not not fitting anywhere. So, but we are doing that type of cases. And really, sometimes the predictor of mortality, if we see practically, is not that much that is we think of in anesthesia perioperatively. So, what you say on that? If your boss is saying that okay, whatever the patient is, but I have to do this case, and he is the director of your hospital.
Sir, I'm not. Sir, in between, voice is breaking. I will try to stop my video. Yeah, sir. I get institute director as a cardiac
Okay.
surgeon. No, institute director as a cardiac surgeon. You want to do some case. What case is that, sir? Sir, am I audible?
A- Any case that is not is very high risk, and you are not have the right time to optimize the patient, and he is saying to take it right now.
Okay, sir.
Then what is your say? Because you are a practical guy.
Fine. So, if it is emergency, yes, there's no point of argument. If it is time-sensitive surgery also, we should, if we understand the physiology, then there is nothing wrong in going ahead with the surgery, if provided we have the equipments to monitor also. Because as anesthetists, we can talk so many things. As if until unless we have the whatever clinical knowledge we have, we need some sort of instruments to see that and objectivize everything. Second thing is, if it is elective surgery, just because of we say institute director or not, let's at least we should start learn to say no. At least that learn to say no. Even if it is not first time, second time, we may go ahead. If they burnt their finger, at least they will start listening. Because every time what, as a generally, to be very honest, we say as an anesthetist, so many times we say that okay, they're not giving respect from surgeon. I think respect should be earned once our voices are reached out and we are proven that we are able to capable. That's why I said that as a perioperative vision, we should be in charge. But it's time to change. They will change eventually. I hope I answered the question.
Good. Thank you.
Thank you, sir.
Doctor, I'm extremely sorry, I can't pronounce your name.
No issues, no issues. RSA.
Okay, fine. So you are a cardiac anesthesiologist. It's perfectly fine. But most of the time, if such of the cardiac patients they came into the hospital for non-cardiac surgeries, and many times the regents just place a note in the file. Patient is postponed for optimization. I want this term to be clarified. What does this optimization mean, and what we expect that the patient has this much of the clinical status before going for the surgery?
Correct. So that's what even one of my friend cardiologist asked the same thing. So they say, what do you? I am writing optimization, but I have really no idea what to be optimized. He himself admitted. So if for example, the patient has stented or any coronary artery disease, they are the most common, or in a valvular heart disease patient. If they are, for example, if they are in a beta blockade, we should see adequately beta blockade or not. The heart rate is in a reasonable level or not. If after giving beta blockers also, if the heart rate is not settled, that means they are not optimized. And other problem like diabetes and all, hypertension, again hypertensive guide, like not even 140 130, they should be adequately come down on the BP, say let's like normal or near normal 130 or 80, whatever it is. So it is not just started the drug, whether the drug has reached the patient and the patient has reacted to that, it is very important. This is just two examples I'm giving. Other patient, like for example, they have wet, like congestion is still present, that means there is some dysfunction is happening in the heart, that's why lung is getting congested. So we have to see optimized whether their diuretics is optimized, and what their AC inhibitors are optimized or not. Nowadays, the stable HF patients are coming, very frequently coming. Heart failure is booming now. So those patients definitely will come to you. They will be in a 4 pillars of GDMT, which is ARNI and beta blockers and dapagliflozin and mineralocorticoid receptor, spironolactone. So in that case, whether everything is optimized, for example, you are seeing one day prior the patient, whether the AZ inhibitors are keep going running you want to stop it 24 hours before, definitely you should take 24 hours. We cannot just like that, okay, they've given, we cannot go ahead with the surgery. It has to be, even if 24 to 48 hours, generally we say to stop at 24 hours. Dapagliflozin also to be stopped, because nowadays their term is non-diabetic ketoacidosis and all is emerging. So whatever their drugs, it has acted or not, patient is in a very good condition or not, best possible reasonable condition. So that then the patient should, let's say, optimized.
Okay. In many situations, when the cardiologist treats such patients, suppose if the beta blockers are being given and the heart rate is somewhere around 80 to 90, somewhere between 80 to 90, or just adding over 90, and we send this patient for the optimization to this cardiologist say it is fair enough, there is no problem.
Exactly, sir.
So how should we write it in notes that what I want to be in optimization? What should the pattern of those notes for? This is for the information of the all the regions who are attached with this Zoom conference, and to make them clarify how should we put the notes, what optimization we want.
Well, valid question, sir. Because for them it is 80 to 90 is resting heart rate they are seeing. We are the one who is going to see at the time of stress, like induction, particularly extubation, how heart rate is going to shoot up. So that is that perspective they will never ever understand. So I think probably they will not understand. That's why I'm saying we should be able to, in a position, we can say, see clearly heart rate, I want heart rate of around less than 80, or let's say around, if it is a fully adult patient, somewhere around 60 to 80 is fair enough, until unless the patient is having a regurgitant lesion. So I feel 60 to 80 is the cutoff. So let's come to the conclusion 70 is fair enough, because when we control 70, the moment we start induction, the patient heart rate is somewhere in induction time is going to high. And particularly induction also somehow we can control. I'm sure every anesthetist is nobody is going to leave it. But extubation is the problem where I have seen in my non-cardiac anesthesia practice, one time perioperative MI, type 2 MI. Most of the patient colleague anesthetist also would have seen this type 2 MI in a extubation, where it's tricky. We can't give we want to extubate, and patient might, it's a case to case basis. So that is why beta blockade will give you that leverage for us. So 70 will be.
When any patient comes to you with hypertension and it is first time suppose diagnosed and the surgery was planned, so what is the minimum duration of postponement of the surgery you suggest for starting antihypertensive first time in the patient's diagnosed in PSA clinic?
So there is no clear-cut guidelines how much time, but definitely depending upon the BP, if the BP was coming to the consistently around less than 130 of systolic and less than 80 of diastolic is fine. If anything more than that, if the patient is able to wait for surgery, definitely we should get the antihypertensive and wait for minimum at least, let's say, 2 weeks to 1 month to see whether the response is happening or not. Sometimes they won't respond with single antihypertensive. And in case practically we can go for just put a echo probe, see the LVH. If the patient is having LVH, definitely the patient is chronic hypertensive, which is not presented. Fortunately, they are presented to us. So degree of hypertensive and even ECG LVH strain pattern will tell us what is the degree of hypertension.
So how frequently you expect echo in hypertensive patients?
Echo in hypertensive patient, the most common sign will be LVH only, so nothing LVH will be there. Diastolic dysfunction will be there. That also we can grade and see. As long as most of the echo reports would have seen grade 1 diastolic dysfunction, hypertension. It's very common finding.
Thank you.
Thank you, sir.
Thank you, sir. So moving on with our presentations, and we have the last presentation for the day. So I would like to invite Dr. Guru Sandhya. She's working as an anesthesia consultant at Kumaran Medical Center, Coimbatore, and she'll be talking on the diaphragm sparing techniques for shoulder analgesia, facts and concerns. Over to you, Dr. Guru Sandhya.
Yes, sir. Good evening, one and all. So I'm here at the end of the session where everybody is tired to put here into a shoulder analgesia technique, diaphragmatic sparing techniques, which are there around the clock right now. Everyone is speaking about diaphragm sparing techniques. So I'm here to talk about the facts and concerns of the same. So for any area which is we have to anesthetize for any particular procedure, we always have to see for maybe 3 or 4 parameters which are there. For any place to be effectively anesthetized, we have to see for the dermatomes, myotomes, and the osteotomes. And in case of any joints which are involved, we also have to see about the capsulotomes. So primarily the shoulder joint, whichever is taking place, may it be a shoulder dislocation or arthroscopy or an anterior approach to any shoulder joint replacements, the primary area of concern will be the anterior and the posterior approaches. And the anterior area in the shoulder is actually supplied by the supraclavicular nerves, which are the branches of the cervical plexus, and in the regiment batch area, which is supplied by the axillary nerve. And in the posterior area also, it is supplied by the supraclavicular nerves, which is again a branch of the cervical plexus with a root value of C4. And in the posterior area, it is supplied by C5. And in the medial area, as we all know, it is supplied by the T1 segment and the T2 segment, which is the intercostobrachial nerve. So the anterior region is basically supplied by the C5 and C6 and posterior by the C4 and C5. And the osteotomal supply of humerus and the shoulder joint per se. The shoulder joint is actually divided into 4 quadrants. The superior quadrant is mainly supplied by the lateral pectoral nerve. The inferior quadrant is mainly supplied by the lower subscapular nerve and the axillary nerve. And the inferior quadrant and superior quadrant are majorly supplied by the suprascapular nerve. The shoulder joint itself is made of 2 joints. One is the acromoclavicular joint and another is the glenohumeral joint. And the lateral pectoral nerve has got a root value of C5, 6, and 7. And the suprascapular nerve, which has a root value of C5 and C6, and axillary nerve, which has got a root value of C5 and C6. So, and the myotomes which are involved in the shoulder joint reconstructions or arthroscopies are mainly the rotator cuffs, which are supraspinatus, infraspinatus, subscapularis, and teres minor muscle. Where supraspinatus is supplied by the suprascapular nerve, which has got a root value of C5 and C6 again. And infraspinatus muscle is again supplied by the suprascapular nerve, whereas teres minor is supplied by axillary nerve, which has got a root value again of C5 and C6. And subscapular is supplied by the subscapular nerve with the same root value. And shoulder joint has got an extensive innervation from all the nerves which I've mentioned. And there is a high degree of mechanoreceptors which are present in the acromioclavicular joint section, as well as in the anteromedial section, as well as there is a high degree of nociceptors which are present on the superior surface of the shoulder joint. And the ligaments and bursae also have got a supply from the nerves which I have mentioned earlier, which is the suprascapular nerve and the lateral pectoral nerve. So basically the whole of the shoulder is getting its supply from C5 and C6 nerve root, and that has been always the area of concern. And the analgesia for any shoulder surgery or any surgery should involve a multimodal approach, which using IV agents like paracetamols or NSAIDs or tramadol for the sake. And regional blocks have been always the cornerstone for any shoulder surgeries recently. So the regional anesthesia can be either a brachial plexus blockade or a non-brachial modality. So in the brachial plexus blockade, there is interscalene block, supraclavicular brachial plexus block, costoclavicular, selective upper trunk block, which blocks only the C5 and C6 nerve roots, and the infraclavicular brachial plexus block along with the suprascapular nerve block separately, and individual nerve blocks which will include suprascapular nerve block and the axillary nerve block separately. And the non-brachial modalities will involve cervical epidural and erector spinae block. So in the brachial plexus, there is always a concern. Wherever you go and search for the data, there is always a concern that they will always correlate any shoulder analgesia with diaphragm sparing techniques. There is so much noise that every block whichever you are giving is always related to a hemidiaphragmatic palsy and how the patient is behaving perioperatively. In the interscalene block, dated like way beyond where Vinny has demonstrated first, there is data which says there is 100% incidence of hemidiaphragmatic palsy. There is also measures which has been taken like extrafacial injection of the drug and lower down injection of the, wherever the classical interscalene is given at C6, lower down injection or diluting the drug or minimizing the drug to 8 ml volume has been tried, but there is no data which suggests that it is associated with 0% risk of hemidiaphragmatic palsy in case of interscalene. There is still a risk of 25-20% for the hemidiaphragmatic palsy. But having said that, this is one of the best analgesic regimen which can be given, and it is still the gold standard of analgesia for any shoulder blocks which can shoulder surgery which can happen. Since I have mentioned that C5 and C6 are the main routes which are supplying the shoulder and shoulder joint per se, selective upper trunk block has been developed, wherein the C5 and C6 nerve roots, they form upper trunk and then they travel, then enter into the supraclavicular brachial plexus. Again, this is also associated with hemidiaphragmatic palsy, and it is associated with very good quality of analgesia also. But isolated selective upper trunk blocks and surgical analgesia and anesthesia has to be yet determined. The next block which is to be given, or which is given commonly, is the supraclavicular brachial plexus block, and the incidence of hemidiaphragmatic palsy can range up to 34%. It is still associated with very good quality of anesthesia, and surgical anesthesia is yet to be determined. There is one literature where, across every literature, there is only one block below the clavicle which says it is associated with good quality of anesthesia and analgesia, but 0% incidence of hemidiaphragmatic palsy. That is the costoclavicular block, which is given just below the clavicle. Put your probe inside the clavicle where the plexus are bundled into one, and you can have a single point injection or a 2-point injection, one into the lateral cord and one into the posterior and medial cord, piercing the posteromedial septum. This is one block which is associated with a very good analgesia as well as 0% incidence of hemidiaphragmatic palsy. The next is the infraclavicular brachial plexus block, which is associated with the inferior quality of anesthesia and analgesia, but surgical anesthesia has yet to be determined. And there are two approaches to the major supply of the shoulder joint, which is the suprascapular nerve. The anterior approach, which is associated with 5% incidence of hemidiaphragmatic palsy, whereas the posterior approach is associated with inferior quality of analgesia because all the articular branches to the shoulder joint are given of much proximally rather than near the anterior branch, anterior approach rather than the posterior branch. And there are case reports wherein even our Indian authors like Dr. Sandeep Diwan and Amjit Nair has published in RAPM as well. And there is emerging evidence that erector spinae can be used as a diaphragm sparing block for any shoulder surgery, even for bilateral surgeries. So the spread has been from C3 to T1, which has been effectively questioned, but there was no diaphragm involvement with the limited evidence which Dr. Sui et al. Has shown in the RAPM article. And there are also evidences that the cervical epidural has been performed for bilateral shoulder surgeries. And I had the pleasure of meeting Dr. Ophelia Grimond in the Prague Regional Anesthesia Conference, wherein she has given cervical epidural and conducted lots and lots of shoulder surgeries under cervical epidural alone with no demonstrable phrenic nerve palsy. So all these has to be kept into concern. And what we always see is most of the studies nowadays are emerging, and they have seen for diaphragmatic excursion in the ultrasound. But some studies have shown that even with decrease in the diaphragmatic excursion in the ultrasound, the PFT values were not matching and not decreasing as much as that decrease in the diaphragmatic excursion. So here we definitely need a clinical correlation as how much decrease in the diaphragmatic excursion can lead to a significant decrease in the FEV1 and the PEFR, and the clinical correlation is also very important. Like, when is the patient going to become dyspneic? When is the patient going to desaturate? Will the normal patient desaturate with this much of decrease in hemidiaphragmatic excursion, or a potent area of research? For any block which is studied, a clinical correlation is always important. And with patient with respiratory distress like COPD or bronchopneumonia, obviously we're not going to do any diaphragm involving blocks. We are always going to go for diaphragm sparing blocks. And in normal patients, any block with interscalene is just going to be fine. And how much extent, or we always need to address how much decrease in FEV1 is significant for a normal individual. Is that decrease in like 20% decrease in FEV1 going to affect the patient who is otherwise normal? We are always in the quest of seeing something new. Why can't we stick to older methods like interscalene when the patient is normal? There is always evolving blocks like PENG block for shoulder, there is subscapularis facial plane block. So we are always constantly evolving for something new. But evolving is always great, but do we need a constant search? Like, even in the interscalene block, we can see how many patients are going for decrease in diaphragmatic excursion, and how many patients do they really land up in dyspnea, or do they really land up in desaturation is a potent area of research. So again, we are there is partial of evidence in paucity of evidence in erector spinae block, as well as the costoclavicular block or PLENG block in terms of RCTs for the extents of surgical anesthesia. In the quest of something new, are we always losing the time-tested methods is what I want to ponder in this presentation. So we are in constant search for something new, but is it warranted in every other patient who is normal? This is the question which I want to post for myself when I'm looking for something new like PENG or ESP when I'm doing on a patient who is otherwise normal. In any case, in patients going for a shoulder reconstruction or shoulder analgesia or arthroscopic surgeries. Thank you.
Over to the judges.
Very good, Dr. Santha. It's a very relevant and very good presentations. You have differentiated different type of blocks as well as the complication which we can face here. So, suppose because you have chosen the topic for analgesia, cup anesthesia for the shoulder surgeries primarily. So, considering that shoulder surgery, which block is should be chosen, and what is your take home? Whether
I
it
will
is
always,
cervical,
if the
epidural.
patient is a ASA1, otherwise with no respiratory, even if it is ASA2, otherwise with respiratory parameters are normal, I will still stick on to interscalene block, which is the time-tested gold standard block. Now,
Okay.
I have just put the analgesic options wherein if the patient is going for a bilateral surgery, then non-brachial options can be there.
Okay.
Even with the non-brachial approaches, they have seen that they have mentioned that the diaphragm sparing is still there. They are able to establish a differential blockade with only cold sensation gone from C3 to T1, but diaphragm was literally spared.
Okay, fine. So that means the time tested as well as most practice blocks should be opted first rather than
Yes, sir.
going for non-tested and non-experienced blocks.
Yes, sir.
Okay. So there is one more question. It is just considering all the regents and the practitioners who are practicing. So
Yes, sir.
if we have a trauma, if we have a polytrauma patients and there is a thoracic injury
Yes, sir.
as well as upper limb injury on the same side with shoulder
Okay, sir.
injury, would you go for block on that side?
On the same side, sir.
Same side.
Provided that
Thoracic
there are
as well as
no,
limb.
provided that there are no nerve injuries which are associated with the upper limb, I would go for a diaphragm sparing one, which is below the clavicle, a costoclavicular block.
Costoclavicular. And
Yes.
what about if the clavicle is already fractured?
If the clavicle is already fractured,
Yeah. If there is a clavicle fracture,
yes, sir.
there is a fracture of surgical neck of humerus, the clavicle fracture, and the same side thoracic injury.
I would go for supraclavicular brachial plexus block with low volumes.
Okay. So it will be what equipment will you would you prefer to use for this?
I would use ultrasound guided low volume, maybe say 15 mils to 20 mils of local anesthetic in the supraclavicular brachial plexus block with ultrasound guidance.
So would there be any changes in the drug as well as volume?
Yes, sir. I would use only analgesic blockade with 0.2% of ropivacaine. With volumes limiting, I can target each of the trunks separately, sir. With the inferior trunk, I will give only infiltrate only 5 mils, middle trunk 5 mils, and upper trunk 5 mils with 15 mils.
So,
or still, if I have to still come down, then I can give an isolated suprascapular nerve block and axillary nerve block. I'm not quite well versed with, so I would still stick on to supraclavicular brachial plexus block.
Okay, so what complication do you expect in this patient with the polytrauma on the same side with the clavicular, so that everybody should be aware of those complications and should take care?
I would refrain if it is the opposite side, sir. Since it is the same side, already the patient has got a compromised lung, and the same side, if I'm giving phrenic nerve blockade, it is fine. But if I am going to give it on the opposite side, interscalene, and if I'm risking the phrenic nerve palsy on the other side, then I'm a bit more worried than the puncturing on the same side. If it is on the opposite side, then definite no. I would still go for any infraclavicular, below clavicle plexus blockade.
Thank you.
Thank you, sir.
Dr. Sahu, please.
Dr. Sarvana, we are listening you. You are saying I am the last, but we are listening and we are enjoying. So what is your experience in this erectrospinal plane block for
no, sir. Basically, no, sir. My erectospinal blocks have always been for rib fractures or any surgeries involving the anterolateral aspect of the chest wall, and it has never been for any shoulder surgery, sir. As I said, I am just sticking on to something which is time tested. I haven't even. I haven't practiced even PENG, sir. I just keep reading, but I haven't practiced PENG also.
Yeah. So in So intrascalene is the best, as we have also practiced this since years.
Yes, sir.
Or you compare intrascalene versus infraclavicular, which is more better?
Sir, intrascalene with
Infraclavicular approach.
infraclavicular alone will not provide an effective analgesia for the
Yes.
shoulder, sir. It is
As
if I
high
have
you
to,
go, the
better
effect will be
the
higher. Yeah.
yes, sir.
Good. Thank you.
Thank you, sir.
Thank you to our esteemed judges for giving their
Thank you, sir.
valuable time. And thank you to all the presenters for such vast array of presentations. It seemed more like the recent updates and the recent ongoing researches and hot topics, burning topics that they have come and they have brought it on the platform. So thank you so much for sharing and discussing such concerning topics and yet very interesting. So we thank all the presenters and our judges for their valuable time. I would ask Naveen sir, if sir is there, if you any concluding remarks or
And
any
we all the chairpersons thankful to the Dr. Nitin Chaudhary and Dr. Neha for giving all the time and dedication to make this show very successful.
Thank you so much, sir. So any concluding remarks? Any concluding remarks from our judges? I mean, for us as the young anesthesiologists, maybe, so that we can gain something from your experience. To the presenters.
Definitely, we will like to congratulate all the presenters who presented themselves at national platform. And I found them, they are really very good. They have prepared the topic. The slides were very great. And the way of presentation, their confidence, their review on the current literature, and their personal experience add-on will definitely give insight to the coming budding future anesthesiologists. So from us, all the best and very thank you.
Thank you so much, sir.
नितिन मोहन भागवत जी ने कहा है कि 75 इयर्स होने के बाद शॉल ओढ़ने के बाद इसका मतलब है नए लोगों के लिए जगह छोड़ दी जाए. सो दे आर द फ्यूचर ऑफ ऑल द एकेडमिक एक्टिविटीज एंड वेरी गुड प्रेजेंटेशन, वंडरफुल.
Thank you, sir.
By all.
Thank you so much, sir. Thank you for your time, your comments, and I'm sure it will help us to reach greater heights. Thank you, sir. So, is Naveen sir there?
No,
okay. So thank you. So thank you to all the presenters. We'll conclude today's state, sir. Call, sir, do you wish to add anything?
Sir is there, yes. Call, sir.
Call, sir, please.
Thank you. Good night. So you are muted,
sir.
Sir,
you're mute. Call, sir, you're mute. Can you unmute yourself? Yes, sir, please.
Excellent presentation by everybody. Great job done by the chairpersons, the moderators, and the coordinators. Everyone has done a great job. Thanks to everybody and congratulations to everybody. I don't know the result, but in my opinion, everyone is the winner. Whosoever has presented is the winner. Best luck to everybody. Keep it up. Keep it up.
Thank you, sir. Thank you. We need your constant support and your blessings for our future endeavors as well. Thank you so much, sir. So we end here and see you soon in the next Youth Conclave. So we'll update you with the recent the results and all in the next update. Thank you so much. Have a good evening.
Thank you, everyone. Thank you. Long live RSA.
Long live RSA. Yeah.
Long live RSA.